So, sir, is 3, 2, 1. Over to you, sir. We have live to audience, sir.
And start recording, please. So, good morning. Today, again, we are here on the second Sunday of the month of September for another episode of FOGSI ICOG PG Clinic. At the outset, again, and every time, we are thankful to our president, Dr. Sunita Tendulwarkar, and Dr. Parag Biniwala, ICOG chairperson, for giving us this opportunity to continue with this program of PG clinics every second Sunday of the month. All these programs are being recorded and are on the website of the ICOG for the benefit of the student and all the ICOG fellows. Today, we are here to have the program on forceps and ventouse, technical demonstration and key practice points from Dr. Sunesh Kumar. He is the former professor and head of the Department of OBGY at AIIMS, New Delhi. After that, today we will be discussing a case on gestational trophoblastic disease by the students of All India Institute of Medical Sciences, Kalyani, West Bengal. Dr. Pooja Yadav and Dr. Divesh Nitin Maniar will present the case. Dr. Subrat Panda, professor and head of the Department of AIIMS Kalyani, and Dr. Sayani Pai, associate professor, are the coordinator for these case discussion. And we have our Dr. Ashish Mukhopadhyay from Kolkata, Dr. Bhagya Lakshmi Nayak from Cuttack, Dr. Bindya Gupta from Delhi, and Dr. Mukta Agarwal from Patna as an expert, as a teacher to guide the students in this case discussion. After that, we will be having the dummy and pelvis, and we will be having fetal skull and maternal pelvis demonstration, understanding fetal skull and its various clinical importance. Today, we'll be only focusing on fetal skull, bony skull, and Dr. Ashish Kumar Mukhopadhyay will highlight and will teach the student and will tell us about the silent feature of fetal skull. After that, we'll have a quiz on gestational trophoblastic disease, and Dr. Archana Kumari, chairperson of FOGSI quiz committee, will be there to conduct the quiz. So before we start, I would like to invite Dr. Parag Biniwala, chairperson of ICOG, to say a few words.
Thank you, Dr. Ashok. Good morning, all. I bring greetings from ICOG, and it's indeed a pleasure to address the audience today for the 9th time this year. This is the 9th episode of the year 2025 of the PG Clinic. And I must thank the three coordinators of this program, Dr. Ashok Kumar, who is the vice chair of ICOG, Dr. Ashish Mukhopadhyay, and Dr. Hafizur Rahman, who is the governing council member. So all three of them have been conducting this program for almost last 4.5 years. So thank you for being so persistent and taking this activity of ICOG ahead. Thank you, Dr. Sudesh Kumar, for agreeing to be a speaker today. And of course, Dr. Ashish Mukhopadhyay, who will be talking about the dummy and pelvis. Thank you, Dr. Bhagya Lakshmi Nayak, Dr. Vidya Gupta, Dr. Mukta Agarwal, along with Ashish, who will be examining the candidates today from AIIMS Kalyani on GTD. So best wishes to Pooja and Divesh for your case presentation. And special thank you to Dr. Subrat.
I think the connection is interrupted.
I think there is issues with the signals. Yes, is there. Dr. Parag Biniwala, if you are listening us, then just continue.
Okay. So just wanted to thank Archana Kumari and her team for being part of this program. My best wishes. The signal on the road is not that great. So I may not be able to continue listening to the lectures and the case presentation, but I'm sure it will be helpful to all the students who are listening to this program. Thank you and my best wishes.
Thank you, Dr. Parag Biniwale. Before we start with our program, I would like to thanks my co-coordinator, Professor Ashish Mukhopadhyay, for continuing with me for a long time, and Dr. Hafizur Rahman also. Today he will be joining us a little bit late, and Dr. Ashish Mukhopadhyay will continue and conduct the program. And obviously, he has a presentation also on fetal skull. So, just to remind all of you that all these recordings are available on the ICOG websites, and you can take advantage of the recordings of the previous programs of last 4.5 years also. And these cases are being discussed again and again because, in the exam, only few topics which are important and relevant, they are being asked, and the cases are available in the wards of the uh, center, and these are available for the presentation also. So you can repeatedly see the recordings and take the notes from those and try to learn the different aspect of the cases. We are in practice, and it is our always a endeavor that we put different aspect of the same case in different cases. So we are not, we try to avoid the repetition, but yes, to continue today, I just now request Dr. Ashish Mukhopadhyay, sir, to please carry forward. And before that, just a few words of encouragement.
Yes, thank you very much, Dr. Ashok Kumar. Yes, we are continuing with this pleasant task of PG Clinic over last 4.5 years. And thanks to the past chairpersons of ICOG, past presidents of FOGSI, and the present chairperson of ICOG and present president also, because they have constantly encouraged us about continuing this program. And we three of us have been discussing always amongst ourselves about the possible changes in the program which is beneficial for the students. I take this opportunity to thank Dr. Parag Biniwale, Dr. Sunita Tendulwar, Dr. Ashok Kumar himself, and our Secretary General, and also Dr. Sarita. So today, as you rightly heard from Dr. Ashok Kumar, that we have three structured program. The first one is a lecture by our video demonstration come lecture from Professor Sunesh Kumar. Then there will be a case presentation on a relatively not commonly discussed case like gestational trophoblastic disease. And then there will be a demonstration on only head, fetal head in labor and its importance. And lastly, to top it all, we will have the quiz program. So I think that we are constantly changing. And yes, as Dr. Ashok Kumar said, we are repeating the topics also, but that is necessary for the students' point of view also, because the views keep changing, and we want to give you a pan-India view of all the gynecologist teachers who may come to you as external examiner, and they have different styles of taking examination, different approaches to the management of the cases, etc. So we want to expose our students to that. So with those few words, and we would like to continue with the efforts for many more years to come, I now welcome the first session, that is Dr. Sunesh Kumar, to kindly, he has already committed to us that he will speak on the technical demonstration of forceps and ventures and the key practice points. He is a former professor and head of OBGYN at AIIMS, New Delhi. All of you know Dr. Sunesh Kumar. We have a very pleasant association for a long time in the past. So, Dr. Sunesh Kumar, are you ready with the presentation, sir?
Yes, sir, I am ready.
Thank you, sir. Sir, the floor is all yours, sir.
Thank you. All of us, when we conduct delivery, often face a situation where patient is trying her best to push the baby and she is not able to. In this situation, it comes to our mind, can we not pull out the baby? This kind of feeling has always been there since deliveries are taking place. And it seems it was this feeling which led to origination of phase and vacuum. Forceps and vacuum are devices which are applied to fetal head when cervix is fully dilated to expedite delivery. History tells that probably first time use of forceps started in UK. There was a family of doctors called as Chamberlain. For 4 generations, they passed on this secret to their family. All these doctors used to be family physician to royal family. It was the last of the generation that they decided not to become doctor, that the secret came to be known to rest of the medical world. Forceps and vacuum are instruments which are applied to fetal head in second stage of labor for some indication. It may be that fetal heart is becoming slow, fetal heart is irregular, there is a passage of meconium, or there is cord prolapse. So these are fetal indications where we decide to use forceps. Sometimes we decide to use forceps because mother is suffering from heart disease and we don't want her to push because this will burden her heart. Same thing applies if she has lung disease, she has neurological disorders. Another common indication for applying forceps is she has severe preeclampsia or eclampsia. We also decide to use forceps in a case of antepartum hemorrhage due to abruptio placentae, where labor was induced and she has now reached second stage of labor. At times we apply forceps when she was under epidural anesthesia, she has reached second stage of labor but baby is not coming out. So these are the maternal indication. But the most common indication where we decide to use forceps is prolonged second stage of labor where mother has become exhausted and she is not able to push out the baby. At times people apply forceps when there is neither a maternal indication or fetal indication, and this is called as elective forceps delivery. It is better avoided. For forceps application, it is always better that there is some indication. So, what are the prerequisites which should be fulfilled when we decide to use forceps? Most important is cervix should be fully dilated, head preferably fully rotated, membranes are absent, and we have given some anesthesia before we apply forceps. This anesthesia can be in the form of local infiltration in the perineum, bilateral pudendal block, and in case she is already under epidural anesthesia, that will suffice. Let us look at the instruments. One I am holding in my hand is called as outlet forceps. This one which I am holding in my hand is called as mid cavity or long forceps, and there is yet another variety, and this is called as keel end forceps. There are a number of other forceps, but basically forceps are so designed that they hold on the fetal head. So whether it is outlet forceps or mid-cavity forceps. These are called as blades, and these blades accommodate fetal head. The portion which I am holding is called as handle, and the portion in between blades and handle is called as shank. Difference between outlet forceps and mid-cavity forceps lies in the length of shank and the handle. Blades are so designed that they accommodate head, so there has to be fixed distance between two blades, and this is 7.5 centimeter. Same way, distance between tip of forceps blade is also fixed, and it is 2.5 centimeter. If these distances are more or less, it will cause undue trauma to the fetal head or to the pelvis. Most of the forceps application are outlet forceps. We call forceps application as outlet, where head has reached perineum, head is visible in between contraction and is at +5 station. In case we need to apply forceps but head is higher up, +4, +3 station, it is called as low forceps. If we apply forceps for some indication where head is between 0, +1 or +2, it is called as mid-cavity forceps. Higher the station of the fetal head, more difficult it is, and it is more likely to cause trauma to the fetus and to the maternal tissues. I will now first describe how do we apply outlet forceps. In case we decide to use forceps, we have to fulfill prerequisites, and these are: cervix should be fully dilated, membrane should be absent, head preferably fully rotated, and there is no CPD. Patient is preferably brought to the edge of the delivery table. We should empty the bladder with the catheter just before applying forceps, and we should give anesthesia. For outlet forceps, local perineal infiltration with xylocaine or bilateral pudendal block will suffice. How do we apply? We take forceps blade, assemble them, and see they are locking well. We apply little jelly, xylocaine jelly on the blades, and then we introduce left blade first. We hold forceps blade in a pen-shaped manner like I am holding here, and we first put it in hole of sacrum and then bring it to the side of the head. Once one blade is inside, we ask our assistant to depress the handle, and now we introduce the right blade. Same way, starting from hole of sacrum and bringing it on the side. If application of blade has been proper, they lock easily, and during next bearing down effort, we will give traction to facilitate delivery. Before giving traction for pulling the baby, we see if there is a need for episiotomy. We pull downwards and backwards till occiput is born, and when occiput is out, then we slowly lift the forceps so that vertex, forehead, nose and mouth are born, and only when whole baby head has come out that we remove the forceps blade. after baby has been born, placenta and membranes are out, we carefully look, has there been any extension of episiotomy or has there been any tear in the lateral vaginal wall, and they are repaired. By and large, outlet forceps delivery is a simple one, doesn't cause much trauma to the maternal tissue of fetal head, and this is one all of us should be familiar with. Next, I come to use of low forceps. There may be another situation, patient is in second stage of labor and there is fetal distress and we want to expedite delivery, but we find station is high up, it is +3, +4. So in this situation also we can apply forceps to deliver the baby, but for this we need this other forceps which is also called as long forceps or mid cavity forceps. And let us see how we apply. We have to again bring patient to edge of the table. Do PV once again to be sure of finding that cervix is fully dilated, membranes are absent, there is no CPD, and then we give anesthesia. For use of low forceps, we have to give bilateral pudendal block. In case she is already under epidural, that will suffice. Bladder should be emptied just before applying forceps. So we take forceps, see them, they are fitting well, and then we have to again apply left blade first. A little gelatin jelly is applied on the blades and we hold forceps blade like this and introduce first in hollow of sacrum. With the forefinger of other hand we try to protect maternal tissue and slowly bring blade to the side of the head. Once blade is inside, we slightly depress the handle and then we introduce the other blade same way, starting from hollow of sacrum, bringing it on the side. If application of blade has been proper, that they are on biparietal position, locking of forceps is easy. After application of forceps, next thing we have to do is to give traction during necks bearing down. Before we give traction, see if episiotomy is needed. In most cases we need to give middle-lateral episiotomy and we even ask our assistant to support perineum. And we pull same way. First we pull downwards and backwards till occiput is born and then slowly forwards and upwards so that vertex, forehead, nose, mouth are born. Only when whole head has delivered that we remove the forceps blade. After delivery of baby, placenta and membrane, if we have used low forceps or mid cavity forceps, it is a good idea to explore for extension of episiotomy and explore cervix for any cervical tear. With the use of long forceps, there is always a possibility of cervical tear. So this is how we apply forceps when station is +3, +4. It has not reached perineum, it is higher up. In addition to these two situations, rarely forceps are also applied for other conditions, like there is a malposition of fetus. there is a occipito-posterior position. In occipito-posterior position, occiput of fetus lies close to the sacroiliac joint. In this situation, when patient reaches second stage of labor, if contractions are good, pelvis is adequate, baby head size is average, in most of the cases, head undergoes spontaneous rotation by 3/8 of a circle and occiput comes to lie anterior, and it is born normally. But in some cases, when it was occipito-posterior, head, instead of rotating anterior, rotates posterior to become direct occipito-posterior. It is also called as face to pubes, and then delivery can take place. But in face to pubes, often delivery may be difficult, and in face to pubes, since biparietal diameter is close to anus, there is a possibility of complete perineal tear. Another thing which can happen when it was occipito-posterior, head rotated anteriorly, but it could rotate after it rotated by 15 degrees. After it rotated by 45 degrees, it comes to lie in this position, which is called as right occipito-transverse. Occiput is on the right side, sagittal suture is in the transverse diameter of the pelvis, and it is not able to rotate further. Such a situation is more likely if pelvis shape is android. This condition is called as deep transverse arrest, and in this case we will have to help the patient by one of the methods. So I will now first describe if our patient has developed direct occipito-posterior, or in other words, occiput rotated posteriorly. As I mentioned, delivery is possible. Here what happens, the forehead or sinciput hinges behind symphysis pubis, and slowly first occiput comes out, followed by vertex, forehead, nose and mouth. In case delivery is not taking place, then we can use forceps for facilitating delivery. And let us see how we apply forceps if it has become direct occipito-posterior. For this, we have to fulfill prerequisites. We bring patient to the edge of the table, put in a lithotomy position. Do PV once again to be sure that cervix is fully dilated, membranes are absent, CPD has been ruled out, and we have given bilateral pudendal block. So we take forceps, see these forceps blade, they are looking easily, and then holding the left blade in this fashion, we introduce it in whole of sacrum to bring it on the side. After left blade has been introduced, we introduce the right blade same way. After applying blades, next thing we have to do is to pull on the fetal head. In case it has become direct occipito-posterior, the direction of pull is reversed. We have to first pull forwards and upwards till occiput is out, and once occiput is out, then we take forceps handle like this so that vertex, forehead, nose and mouth are bone. So this is the point to be remembered when applying forceps for direct occipito-posterior, that direction of pull is reversed. Whenever we use forceps for delivery, we have to simulate the normal mechanism. And I just mentioned that in phase 2 pubes, it is occiput which has to come out first, followed by vertex, forehead, nose and mouth. Here again, after baby has been delivered, we look for extension of episiotomy. We should explore cervix for cervical tears. In direct occipito-posterior or phase 2 pubes, there is always a chance of complete perineal tear. So episiotomy is must. So is support by assistant to support the perineum. Next, I will come to the use of forceps and other instrument in deep transverse arrest. In a case of occipito-posterior, if shape of pelvis is android, where anterior half of pelvis is narrow, what happens after head rotates and once sagittal suture comes in transverse diameter, it is not able to rotate further. And this situation is called as deep transverse arrest. There are three words: deep, transverse and arrest. Deep means head is deep in the pelvis. It is +3, +4 or +2 station. Transverse means sagittal suture of the fetal head is in the transverse diameter of the pelvis. And arrest means more than 2 hours of second stage in a primary and more than 1 hour of second stage in a multi has passed and yet head is not coming out. This limit of 2 hours in primary, 1 hour in multi is stretched to 3 hours in primary and 2 hours in multi in case patient is under epidural analgesia. So let us see if the patient has landed up in deep transverse arrest, how to deliver her. If she has landed in deep transverse arrest, we should carefully reassess her. If there is any fetal distress, if there is any CPD, it is better we take her up for a cesarean section. In case there is neither fetal distress nor CPD, then we have the option. One option is we can apply vacuum cup on the fetal head, and with vacuum head will not only rotate but it will come out. Vacuum for deep transverse arrest is a good idea. As I mentioned, it causes rotation of the head as well as delivery. But the use of vacuum in deep transverse arrest, and that is if already a big caput has formed, then when we begin to pull on the vacuum cup, it may slip off. But still, for all practical purposes, vacuum is a better idea in deep transverse arrest. One I am holding in my hand is a vacuum. It is metal cup. We have similarly plastic cups, we have cylindrical cups, and these vacuum cups come in various sizes. One in my hand is 60 millimeter in diameter, others are 40 millimeter, 50 millimeter. Let us see how we apply vacuum cup. So she is in lithotomy position, part has been cleaned and draped, bladder has been emptied. We have given dilated pudendal block. We do PV once again to be sure of our finding. We want to see which side is occiput, which side is inciput, and then we take vacuum cup in our hand And to introduce, we introduce like this. Once cup touches head, we turn so that it is now on the scalp. It should be as close to occiput as possible. And before we create vacuum, we should pass a finger around to be sure that no part of maternal tissue is included in this. We slowly build up vacuum. Initially, we create up to 0.2 kg per square centimeter, and after waiting for 2 minutes, slowly go on increasing vacuum at a rate of 0.1 kg square centimeter per minute. Once we reach vacuum of 0.81 kg per square centimeter, we are now ready to deliver the baby. When we deliver the baby by pulling on the vacuum cup, with finger of other hand we keep vacuum cup pressed against the head. Otherwise, when we are pulling, quite often cup slips off. We should pull on the head when she is bearing down. And as we pull, slowly head will come down, and it also undergoes spontaneous rotation. Only when whole head has delivered that we now remove the vacuum cup. So in deep transverse arrest, vacuum is a good idea because it causes rotation of the head as well as extraction. But only problem is if there has been a big caput formation, vacuum cup may slip off. In deep transverse arrest, there are other ways of delivering, and one is we will catch the fetal head with hand, bring occiput anterior, and after we bring occiput anterior, then we will apply forceps. This is called as manual rotation followed by forceps extraction. This procedure preferably be done in OT. One should preferably give general anesthesia for this, or if he is already under epidural. Otherwise, what happens when we introduce finger in the vagina to grasp head, patient often doesn't cooperate. So let us see how we conduct delivery in deep transverse arrest by manual rotation followed by forceps extraction. So she is in lithotomy position, part has been cleaned and draped. We have done PV once again to be sure of our finding, and we make out which side is occiput, which side is inciput, and then we assemble the blades beforehand to see if they are fitting well. We hold head like this, 4 finger on one parietal bone and thumb on the other. Before we grasp the head like this, we give little pressure on the inciput to cause flexion of the head, and then other hand is placed per abdomen on the anterior shoulder. In between contraction, we rotate the head to bring occiput anterior. We do little over rotation by 10 or 15 degrees. And once we have rotated the head, then we introduce the blade. We introduce left blade like this. And once blade is gone inside, we can take out our finger. And same way, now introduce the right blade. After application of the blade, next thing is to deliver the head by traction on the blade, on the forceps. Before we give traction, we should always give episiotomy and ask our assistant to support the perineum. We pull downwards and backwards till occiput is born, and then slowly forwards and upwards so that vertex, forehead, nose and mouth are born. So this is how we carry out manual rotation followed by forceps extraction in deep transverse arrest. I'll repeat once again. So she had deep transverse arrest. We decided to use manual rotation followed by forceps extraction. We did preferably such a thing in OT under anesthesia. We had fulfilled all prerequisites like she was in lithotomy, part clean and drape, PV done to be sure that cervix is fully dilated, membrane are absent. And then what we did, first thing was to press on the inciput to cause flexion of the head, and then we grasp the head like this. 4 finger on anterior parietal bone, thumb on the posterior parietal bone. The other hand we place over the anterior shoulder per abdomen, and we rotated the head to bring occiput anterior in between contraction. Simultaneously we go on rotating shoulder, and we had a little over rotation by 10 or 15 degrees. After having achieved rotation, then we had introduced the left blade. And here this look, in order to introduce blade, I have to remove my thumb. So sometimes what happens when we remove thumb, head just spontaneously goes back to its original position. So this is one disadvantage of using right hand for rotation of the head. In case it happens that we were rotating with right hand, and when we just attempted to introduce blade, head slipped back to its original position, in that case the solution is we can use even left hand for rotation, and there this problem will not be faced. Another method of delivering baby head where patient has landed up in deep transverse arrest is use of keel and forceps. Have to fulfill prerequisites. Sheath in lithotomy position, part has been cleaned and draped. We have done PV once again to be sure of our finding, to make out which side is occiput, which side is inciput, and rule out CPD. We assemble blades in front of the perineum like this, and if we see, these are two little knobs on the blade, junction of shank and handle. They are to be on the same side as occiput. So after assembling blade, we rotate forceps like this, and now this is the anterior blade. In keel and forceps, we always apply the anterior blade first. How do we apply? We hold like this. We introduce blade in hollow sacrum and sweep it slowly over the face to bring blade anteriorly. So I started from hollow sacrum, slowly sweeping over the face, I brought it anterior. After anterior blade has been applied, the posterior blade is applied directly. After applying keel and forceps, we have to do two things. One, we have to rotate head to bring occiput anterior, and then is traction to deliver the head. We should do rotation in between contractions. If rotation is not possible at this level, we can slightly push the head up and then rotate. And see, I'll rotate this way to bring occiput anterior. After occiput has been brought anterior, during next contraction or bearing down effort, we will apply traction to deliver head. Before that, episiotomy must be given, assistant should be supporting perineum, and we pull downwards and backwards till occiput is moved, and then slowly forwards and upwards so that vertex, forehead, nose and mouth are moved. After head is delivered, then we remove the plate. So this method of applying keel and forceps, where I had applied anterior blade, but starting from hollow sacrum and wandering slowly over the face to bring it anterior, is called as wandering technique. WANDERANG, wandering technique. Followed by application of posterior blade. Sometime when we decide to use keel and forceps, head is very low down and there is no space to wander the anterior blade. In that situation, we can directly apply anterior blade, and let us see how we apply. So same prerequisites: sheath in lithotomy, part clean and drape, PV done, and short cervix is fully dilated. And we take anterior blade and we introduce directly. With forefinger we protect tissue, anterior vaginal wall, and introduce blade slowly like this. After anterior blade has been applied, we apply the posterior blade directly. And this method of application of keel and forceps is called as direct application. There are not many obstetricians who are trained or accustomed to using keel and for delivering head in deep transverse arrest with use of keel and it is more likely to cause trauma. Over the years, what has happened, all of us have become more experienced in doing cesarean and are losing touch of conducting delivery with the application of forceps and instruments. So this is how we manage a patient who had landed up in deep transverse arrest. There is another use of forceps, and that is in after coming head of the breech. Suppose patient had breech dentation, we decided to go for assisted breech delivery. After trunk and neck are bone, mostly we do one Marshall technique to deliver, where we hold baby at the ankle joint, and after making baby trunk taut, we take it towards abdomen. This technique has one disadvantage, that sometimes instead of head coming out, the neck may become extended. So in assisted breech delivery, some obstetricians prefer to use forceps for after coming head, and that is a better idea. Application is same way. We need help from the assistant who will hold the baby up like this. We introduce the left blade, pulled by the right blade, and then we pull. we pull downwards and backwards till nose and mouth bone and then slowly take it upwards. So if we decide to use forceps for delivering after coming head, it is a better idea in the sense that here we are able to maintain flexion of the head. We are directly pulling on the head and not on the fetal neck. And then here blades of the forceps are protecting fetal head from undue compression by the maternal tissue. So these are the indications for using forceps in obstetrics. Only other situation where people at times use forceps is in a case of face presentation, where it is meant to anterior position and head is not coming out. There was a time when cesarean was considered unsafe. So there used to be an attempt to deliver all patient vaginally, and it was in that era that all these things, forceps, ventus, they were widely used. But as slowly cesareans have become much safer, the use of forceps for difficult deliveries is going down, and currently it seems only 3 to 4% of our deliveries are by use of these instruments. So I'll finish by saying this, that is there any place of forceps and vacuum in our country? We have such a large country, at times one may be posted in a small peripheral hospital where it is not easy to arrange for an anesthetist for cesarean. So still there is some place for use of forceps and vacuum in difficult cases. Thank you.
Thank you very much, Dr. Shunesh Kumar, for that
If you
excellent.
give me another 2 minutes, I'll just like to describe a new technique which WHO is advocating for conducting delivery, and that is Odon device, ODON.
Yeah.
Something that, can I take 2 minutes?
Yeah. Sure.
It is something very simple. If you can see in my hand, I am holding a polythene bag. This was a fellow Odon from Argentina. It seems his wife was in second stage of labor and was taken up for cesarean for failing to deliver. He was a car mechanic. He later went to his obstetrician and said, "Sir, can we not just supply something like this, slip it over the head, and then pull it?" Initially, obstetrician laughed at him, but he later on think what he's saying is a good idea, and it was tried. And use of such a simple thing, a polythene device, which is slowly passed over the head in second stage of labor, and when it goes beyond the neck, there's a string there, you can tighten that and then pull on the hand. And this has been tested, this has been in fact undergone controlled trial, and the reports from France, where they found it is successful. Only problem is it initially takes about 5 minutes time to be able to apply device over the fetal head. Such a simple thing, not very costly, and now this company BD, company which markets these syringes, have come out with a device similar. What they have done, they have added handles to the lower end of the polythene. So this is how sometimes even simple ideas can be great. And WHO feels that if we advocate such a simple thing in countries where it is not easy to have access to trained obstetrician, this can help. So there are now publication in the journals where they show that it is an effective device, Odon device. Somebody asked this fellow car mechanic, how did this idea come to your mind? He said, if you have a bottle of wine, usually there's a cork at the top end of the bottle, and sometime when this cork goes inside, we put in the polythene and pull, and this is how we are able to get out of the cork. So this Odon device probably is going to be more popular in time to come. I'll stop here. I'm sorry, in the last part of the video, somehow it went very fast. Not from my end, but slowly over time, cesareans are becoming more safe, popular, easier to do, and people are more experienced in doing cesarean than applying forceps. I'll stop here. Thank you.
Thank you, Dr. Sunesh Kumar. It's always a pleasure listening to you. And I was reminded of your old days at AIMS when I used to observe you and your students. You were such a popular teacher there. It also kept the memory of the good old key lens forceps alive in the memory of the students. And I believe that this is a forgotten art today. And the students may not learn this as meticulously as Dr. Sunesh Kumar demonstrated. He's an expert in that. But in the exam, you will not be asked about this. So I think it's just a question of, remembering the good old art. And he's right that everywhere the trained anesthetist and the setups may not be available for a C-section. I know that the students are the budding students or the next coming out students, they are more comfortable with the cesarean section. And this comfort has been transferred somehow to the patients also and the relatives. So I think that that actually reminds us of the clinical art, which has to be there in situations where it demands. So thank you, Dr. Sunesh Kumar, for that wonderful presentation. And also that initially we had a little bit of hitch in the video, but later on it was running a bit fast, but we could catch up because your speaking style is so absorbing that everyone was glued to the screen while you were speaking. Thank you very much for joining us. And students, this will be available in the website as recorded format, so you can go back and listen to him. It's a very pleasant lecture. Thank you very much once again. Since we have time
Thank you, Dr. Ashish.
Thank you so much. Thank you. And we will now go straight away to the second part of our PG class, and that is the obligatory by NMC norms. That is the case presentation. And today we have relatively less common presentations of gestational trophoblastic disease, which will be done by the Institute, All India Institute of Medical Sciences, Kalyani, West Bengal. And the PG students are Dr. Pooja Yadav and Dr. Divesh Nitin Maniar. Both are second year PGs of OBGYN. Their coordinator faculty, we cordially welcome. We're blessed to have Dr. Subrat Panda, the professor and head of OBGYN of AIMS Kalyani, and also my dear student, Dr. Shayanti Pal, associate professor at AIMS Kalyani. So I welcome all of you for this presentation. And the faculties to join me, we will have Dr. Bhagyalakshmi Naik, a renowned professor from Cuttack, and Dr. Bindiya Gupta, professor of UCMS and GTV from Delhi, Dr. Mukta Agarwal, my dear friend Mukta from All India Institute of Medical Sciences, Patna. So I think we are going to have an absorbing session on the case presentation on gestational trophoblastic disease. And the total time is 1 hour. I'll invite the students, Dr. Divesh and Dr. Pooja. Are you there?
Yes, sir.
Okay, you are already shared the presentation. You are audible, so you can go ahead with the presentation.
Thanks. Good afternoon, each and everyone present here. Today we will like to present a case. I myself, Dr. Devesh.
And Dr. Pooja Yadav.
We are second year PG residents in AIMS Kalyani, and we'd like to start presenting the case now.
Mrs.
Sorry,
H2.
good afternoon, Dr. Ashish. But I don't know whether it's difficult because their screen is coming on the slide, isn't it?
Oh, it's a PIP mode. PIP mode, it can be removed.
Yes. Can you please stop your screen and first click on that share option, sir?
Yeah. Thank you, Dr. Bhagyalakshmi.
Thank you, sir. Thank you, sir. I think I also enjoyed Dr. Sunesh's talk. It is really so wonderful, so slowly, deliberately told.
Yes, ma'am. He was my teacher in my post-graduation.
Yeah, I know.
And I was taken to my postgraduate days.
Good afternoon, Mukta.
Good afternoon, ma'am.
Good.
Good afternoon. We all were enjoying the forceps.
Yes.
It has taken us back to our PG days.
Yeah.
Thanks to all of you.
Yogita, is everything all right?
Yes, sir.
We are having some delay.
Hello, Divesh sir, can you please share your screen, sir?
Me or you are asking the students, right? We are in the middle of a case presentation.
Dr. Divesh, can you try sharing your screen again?
Yogita, something is ticked yes here. What is that? I think in Mukta's screen. Yes.
Sir,
Once again, the PIP is coming.
Yeah, again your PIP is coming.
I think somehow that PIP has got clicked. So we have to see how it's unclicked or undone.
sir, I have shared one screenshot your Zoom chat box. Please open and select this option.
Can you open the chat box, Divesh?
Yes.
That day when we were doing the trial run, what was the setting in your presentation? That day it was okay.
It was background screen.
Please select contact only, sir. And then reshare, sir.
Come.
I think we will take the next session now because let them fix this issue.
I think Yogita, can you just guide them a bit?
Yes, ma'am. Hello, Divesh sir, first of all, click on that share option.
Yes.
Yes. Now you can see first entire screen option and B side you can see presenter layout option. So first option, contact layout.
There's no such option.
Yes.
This entire screen only.
Yes. And then you can see B side presenter layout. First option you can see contact only. Please select this one and then share.
There's no such option.
First open your Zoom screen, sir.
Opened.
Okay.
You can email your slides also and they can do the presentation and you can speak. That also is an option.
Contact.
Yes. Please select.
Yes.
Otherwise, sir, can you please share your slide in
Yes.
Zoom chat box? So
Yes.
yes, now please open your slide. Right now your screen is visible. Please open your slide.
Yes, open it. Yeah, and make it full screen.
Yes.
Now it's okay.
Yeah, perfect.
Yeah, go ahead. Divesh and Pooja, please.
Yes.
Mrs. HP, 23-year female residing in Nadia, West Bengal, 25 kilometers away from hospital, homemaker by occupation, Muslim by religion. Date of admission is 30 of August 2025 and date of examination is 12th of September 2025. Patient presented with chief complaint of irregular vaginal bleeding for past 3 months. History of present illness. Mrs. HP reported to AIMS Kalyani OPD 1 month back with history of irregular vaginal bleeding for 3 months. Bleeding started following a surgical abortion done 3 months back on 15th of June at a private nursing home. Bleeding is intermittent, requiring 1 pad per day, which is partially so, not associated with pain. A patient was visiting the private setup where she had her surgical abortion and was advised weekly blood investigation. According to her, blood values were falling initially for 1 month. Then there was a rise for which she was referred to tertiary healthcare center. There is no history of any abdominal swelling or pain. There is no history of heavy muscle bleeding, painful menstruation, foul smelling, vaginal discharge, fever or night sweats, and alteration bowel or the bladder habits. There is no history of dyspnea on exertion or palpitation, no history of chest pain, cough, hemoptysis, headache, blurring of vision or seizure, or intake of any hormonal medicines. Obstetric history. Married for 2 years. Obstetric score is para 1 with 1 abortion. She had her LMP on 17th of March 2025, spontaneously conceived, unplanned pregnancy, confirmed by home-based UPT. She started having bleeding per vagina, which with passes of grape-like vesicles associated with crampy abdominal pain at 3 months of pregnancy. He visited a private clinic immediately and was advised for ultrasound and blood investigation. She was diagnosed with failed pregnancy and underwent surgical abortion on the same day, and the procedure was uneventful. She was advised to send pregnancy tissue for pathological testing. Post procedure, she was advised with weekly testing of the blood beta HCG. Menstrual history. LMP is 17th of March 2025. Menarche 12 year of age. Past menstrual history were regular. Duration was 4 to 5 days. Flow was average, not associated with pain. Past history. There is no history of diabetes mellitus, hypertension, or thyroid disorder, any chronic disorder, or the prolonged hospitalization. There is no history of tubercular contact, no history of surgery in past, and no history of blood transfusion in past. Family history. No history of suggestive of hypertension, thyroid disorder, diabetes mellitus, chronic illness, or similar history of any disease or a malignancy in family. Socioeconomic history. The education of the head of the family is up to 6th class, which is given score 3 according to the modified Kupusamy scale. And occupation of the head of the family is unskilled worker, which is score 2, and the family income per month, which is 20,000, and score is given 10. Total score is 15. So according to the modified Kupusamy scale, she belongs to the middle socioeconomic class.
Personal history. Bowel habits are normal. Bladder habits are also normal. Sleep is recently disturbed due to anxiety, but not on any medication. Appetite is normal. There's no history of any contraceptive use till date. There's no history of any allergy or any addiction. There's no history of prior blood transfusion. Dietary history. She consumes mixed diet, around 2,280 calories per day in 3 major meals, and total protein intake is 48.6 grams, recalled by 24 hours recall method. On physical examination, patient is conscious, alert, and cooperative. Build is average. Nutrition is adequate. Height is 155 centimeters. Weight is 55 kgs, and BMI is 22.89 kg per meter square. Temperature is normal. Pulse is 78 per minute. Regular, normal volumic, no radial or radiofemoral delay. Respiration is 18 per minute. Thoraco-abdominal. Blood pressure is 100 by 70 millimeters of mercury, measured in sitting position in right arm. Pallor is mild. Icterus, sinuses, clubbing, and pedal edema absent. Lymphadenopathy absent. Tongue, teeth, and gums are healthy. Neck glands and veins are not palpable and not engorged, and no thyromegaly. CNS examination, no abnormality detected in systemic examination. In cardiovascular examination, S1 and S2 are heard, and no abnormal sounds heard. In respiratory system, bilateral vesicular sounds heard, and no added sounds. Abdominal examination, inspection of the abdomen. Abdomen is scaphoid in shape. Umbilicus is centrally placed and inverted, and all quadrants are moving equally with respiration. No dilated veins, lump, or fullness in the abdomen. No visible scar. Palpation, superficial palpation, temperature is normal. No superficial tenderness. No localized lump palpated. Deep palpation, no rebound tenderness, no organomegaly or palpable lump. Percussion, tympanic note present. Auscultation, bowel sounds present. Local examination, vulva is healthy looking, no abnormality detected. In speculum examination, vagina is healthy looking, smeared with blood, no abnormal vascularity or nodule noted. Cervix looks healthy with mild fresh bleeding seen coming from the external os. On bimanual examination, uterus is soft, anteverted, and uniformly enlarged up to 10 to 12 week size, mobile and mildly tender. Bilateral forenesses are free and non-tender, and Peoria is free.
Mrs. HP, 23-year, a para 1 with abortion 1, presented with history of irregular vaginal bleeding for 3 months, which started following surgical evacuation done in private setup in view of failed pregnancy at 3 months of gestation, associated with passes of grape-like vesicles per vaginum. Following the procedure, she was advised weekly beta-HCG testing, and it shows a rising value after 1 month. There is no history of cough, hemoptysis, or any other systemic symptoms. On examination, she had mild pallor, vitals within normal. Per abdominal examination is unremarkable. Per speculum examination, suggestive of normal looking vagina with cervix with mild fresh bleeding from external os. On bimanual examination, showed uterus is soft, uniformly enlarged up to 10 to 12 weeks, mild tender, bilateral fornix, and POD free.
Provisional diagnosis, a 23-year-old para 0 abortion 1 with gestational tropoblastic neoplasia. Points favoring the diagnosis is history of persistent bleeding per vaginum for 3 months following suction and evacuation, history of passage of grape-like vesicles during the antecedent pregnancy, and history of beta-HCG rise over the observed time period after suction evacuation.
Is that
Yes,
all?
yes, sir.
Okay. So you have finished. Now, do you have any differential diagnosis?
Yes, sir.
Yes.
Differential diagnosis would be incomplete abortion, threatened abortion, chronic ectopic pregnancy, cervical tropion, cervical cancer, an endometrial polyp, submucous fibroid, or uterine perforation following surgical abortion, or an arteriovenous malformation.
Okay, so you have so many DD, then it will be so difficult for you to actually reach the diagnosis, 1 page of DD. So what will be your nearest one? Which will be your nearest differential diagnosis?
Complete abortion.
Sorry?
Incomplete abortion.
So how will the history be different from the history which you have got in this case?
There will be persistent heavy bleeding per vaginum following the procedure.
And then the most important thing is she has given you the history of passage of moles. So there is no history of passage of moles. So this is not this one. And there is no pain at all. So that is also, if there is little RPOC, so she may have some kind of spasmodic pain also along with that. And maybe a foul smelling discharge would have happened because it's already now 3 months old. Yes. And then next.
Diagnosis of incomplete abortion was there when she visited the first private clinic. At that time, she was already having bleeding with passage of clots. So at that time, that particular consultant might feel that it could be an incomplete abortion or it could be a molar pregnancy. Threatened abortion is not a diagnosis because she visited the
Never
clinic.
had, yes.
Yeah, already she was bleeding. And cervical cancer and
Yeah,
all
why
the
cervical
gynecological-
cancer? Why cervical cancer? Because your cervix is absolutely healthy, which you've mentioned in your speculum examination.
A
So why do you think
23-year-old,
cervical cancer?
and we are thinking of obstetric causes. She's pregnant.
No, it's fine. But Divesh,
It's
can you
fine.
explain why you thought that we could think of cervical cancer as
Yeah.
one of the DD?
Can be early pregnancy with cervical cancer, fine. But then why
Yeah,
cervical
let him
cancer?
tell why, how it's actually a little wild thing to think. But then still, because they have thoughts, or you give me a point that why it could be a cervical cancer also.
Only according to the symptoms, she had irregular bleeding per vagina, could be after post-coital bleeding, which she is not telling us. But cervix was absolutely healthy at that moment, but only by symptoms, it was one of my differential diagnosis at that moment.
So is there a cervical cancer in which the ectocervix will be healthy?
Yes, ma'am. In endocervical adenocarcinoma, ectocervix
Yes.
would have
So
been
that
healthy.
could be, if you tell it could be endocervical
Yes.
lesion or a polyp or whatever, then we could agree on that. Because cervix you have written, it is absolutely healthy. Okay.
Yes, ma'am.
Okay, so I think let us bring back the case once again, and they have given a lot of differential diagnosis. What are the investigations that you have suggested or you have got from records? Can you show us?
Sir, this investigation we will require to confirm the diagnosis of a GTN. And also staging of the disease. We will require
Excuse me, sir, can I just interrupt here? Just one thing in examination. They said local examination is normal. So when you're talking about GTN, which area in the local area which you should never miss when you're suspecting any kind of GTN? You said, no, vulva is looking healthy. What is the most common site which you should never miss?
suburethral.
Yeah, exactly. So benefit of PGs, just wanted to tell that suburethral area is normally we don't look at it very carefully, but when you're suspecting GTN, do have a look at the suburethral area. Okay, and rest is fine. So yeah,
And
sorry.
it may not be always having a nodule. Maybe a little bluish coloration will be the initial signs of that a suburethral nodule is coming up.
No, one basic question arises to the students. You had mentioned in your provisional diagnosis gestational trophoblastic neoplasia. Why no neoplasia? Why don't you call it gestational trophoblastic disease? And what is the difference between the two?
According to the history only, patient had a molar pregnancy. She could tell that she had grape-like vesicles. Following section evacuation, she remembers that she was undergoing weekly beta HCG testing. Initially, there was a fall in beta HCG and it started to rise again. So that
Show your graphs.
I think Divesh, if you tell it is GTD, it will be safer for you because it will include benign and malignant. So when you have a value of beta HCG rising, then you stamp it as a GTN.
Correct. I agree with Bhagyalakshmi because you see, initially you should always say gestational trophoblastic disease. Now, of that, we have two components. Usually, GTN, we refer to a malignancy from the very beginning. That means you are pretty sure, or you have the old records, or history of chemotherapy, or something like that. There is nothing of this sort. So, you should always say gestational trophoblastic disease. And then gradually, over a period of time, giving the different clinical features, matching the investigations, HCG values, etc., they will go to the GTN if it is so. If it doesn't, the GTD is much more commoner than GTN. So I think you should be always saying GTD, gestational trophoblastic disease first. Okay. Now, what is so characteristic about this graph? This graph is important. As you said, there is a fall followed by a plateau. Was there a rise after this? How much time elapsed between the fall and the rise?
Sir, only 1 week. मतलब on 3rd of July, the beta HCG was 14,897, and on 11th of July, it was 17,000. It was more than 10% rise in that date only. And then there was a plateau continuously for next four.
Okay, the rise that you are referring to is not visible in the graph. Anyhow, is even if a plateau is there, that is significant, isn't it? Following a fall, if there is a plateau, that is also significant. Now tell us, if you want to believe that it's a case of GTN, neoplasia, then you have to justify with more. What are the other things that you need to have in the diagnosis of GTN?
Sir, if the plateau of the beta HCG, sir, measured at the 4 level over the period of the 3 weeks or more, if there is a rise of the beta HCG at 3 consecutive weeks over the period of 2 weeks or more, if there is a histological evidence of the carcinoma, if there is a history of clinical and the clinical radiological evidence of the some metastasis.
Okay, so you are saying about the FIGO, this isn't it? The 5 criteria.
Yes.
Okay.
Yes.
Okay, fine, that's fine. Now tell me that is the value of the beta HCG important, or the rate of rise is important, or time is important? Which one is important?
It is the trend of the beta HCG that is important at that moment. मतलब, is it plateauing or is it rising at that time? The over 3
what
weeks.
sir is telling is how much rise. If suppose it was 17,100 and then next week it is 17,200. So what is the rise that you will stamp it as a plateau or as a rise?
If it's a rise 10% of the previous value, then it will consider as a rise, and plateauing is within 10%, and the fall is more than 10%.
Plateauing is 10% rise or within 10% fall also. That is
Yes.
also going with plateau only. Yes.
Correct. Okay. So tell me, since you are still holding the diagnosis of GTN, right? Then you have to tell me what is the 2 most common types of GTN that we see in practice. Then you have to establish the diagnosis, right? You haven't come to a final diagnosis as yet. So what are the things that you need? Tell me, sir, I need these investigations or these more information to get to a final diagnosis. What are the 2 different types that we communicate?
Invasive mole and choriocarcinoma are the 2 most common types of GTN. To establish the diagnosis, we will need at least only beta HCG value can only or a plateau or a rise can only tell us about whether it is neoplasia or not. Then for metastasis, to stage the disease, we might require an X-ray, a USG scan, or a CT scan, or an MRI brain. Depending upon the symptoms, we can do a full metastatic workup and then stage the disease. Is it falling into a low risk or a high risk category?
That comes at a later stage when you want to decide which chemotherapy is going to, according to WHO scoring, etc. All these things will come later. But now, for the time being, do you like to believe that it's an invasive mole or a choriocarcinoma? These are the 2 different, chief types.
Or it is some residual mole only which has been left behind in the uterus.
Yeah.
Because you see that the levels are not going very high because she had a very high level. So I think the first imaging actually will tell you whether it is a residual mole which has been left behind, which has not been completely removed, or as sir has told, it could be invasive mole or anything more than that. Okay, so first is your imaging.
Yes.
So what does the imaging say? Have you done or found the record of imaging?
Yes, sir. The imaging is there is a
What is the imaging which was done?
Show the report.
अभी चलो छोड़ो. Now tell us how you will score it. Suppose now we agree to you that it is GTN. So you now understand that she will need some kind of chemotherapy. So what is, how do you score it? And what is low risk and what is high risk?
7 criteria. We have 7 things that have to be looked for scoring the disease. That is, one is the age of the patient. If it is less than 40 or more than 40, then history of antecedent pregnancy, then interval from index pregnancy, then pre-treatment beta HCG level, then largest tumor size inside the uterus, site of metastasis, number of metastasis, and previous failed chemotherapy. So based on that, we
So
will
she had a
score the
metastasis somewhere.
yes,
What
ma'am.
was the imaging? Can you tell us if you can't show us the report? Just
Tell
tell
the
us
report.
about the imaging.
Ma'am, CT thorax was CT
Then what
thorax.
about the first ultrasound imaging of the uterus? You first tell that.
Yes. 2 into 2 centimeter heterogeneous mass was seen inside the uterus, and adnexia and rest of the abdomen was clear. And in
Divish,
CT,
1 minute. What else? What else do we need to see if there is a mass in the uterus? What else we need to see about the mass?
If there is an
As sir has
increased
told,
trauma,
if you are thinking about it as an invasive mole, so what more do we see on the imaging? That there's a mass in the cavity, that's okay. What else? Which will tell you that it's an invasive mole.
ma'am, we will do also with do Doppler, ma'am, to see the if there is an increased vascularity around the mass, ma'am.
Yes.
Are
what
also
else?
ma'am is saying invasive mole. So what do you want
Invasive
to see?
mole. So where does it invade? What
Where
can
does
we
it
see on
invade?
the?
biometry.
Yes,
Ah,
we have
yeah.
to see whether the lesion is only in the cavity or invading into the myometrium. Vascularity is okay. There will be increased vascularity, but you have to see. So once it is inside the myometrium, then it is an invasive mole, right?
My suggestions will be, while you calculate the score, do not write like this. You make 3 columns, okay? The first is the age, okay? Then you write the actual age, and then finally write the score. If
Yes.
it looks like the age is 0, antecedent pregnancy is 0, everything
exactly.
is 0 and 1, it is not so, isn't it? So to calculate the score, you need to have the age cannot be 0, right? Well, the score may be 0, but age, how much actual age you have to write, okay? So be very careful about this writing system. So according to you, it's a low risk, isn't it? Okay.
So also, as ma'am said, after imaging, what additional imaging did you do to score the patient, and what were the reports of those imaging?
Ma'am, we did a TVA scan to confirm the mass in the uterus.
That you have done. Okay. Second.
Yes, then an X-ray chest.
Okay.
But
What did it
there
show?
was, ma'am, there was some lesion in the X-ray, but it was not clear. So a CT scan was advised. So a complete CT thorax, abdomen, pelvis was done. And an MRI brain was also done. The CT scan showed nodule in the right upper lobe of the right upper lobe of the right lung, and it was around 1 centimeter cross 1 centimeter in size, and a few ground glass opacities beneath the subpleura, and MRI brain was clear. There was no lesion in the MRI.
And ultrasound abdomen was normal. CCT abdomen was
Yes,
normal, I think.
yes, ma'am. CCT abdomen was normal.
So suppose if you now have an X-ray and you have a CCT report, and if your X-ray was not very clear, but suppose if you have a clear X-ray and you have to count the number of metastases, where do you count? You count it on an X-ray or you count it on a CCT chest?
On X-ray.
On an X-ray, ma'am.
Yeah. So number of metastases should be counted on X-ray.
So
Okay.
and the next, so we are discussing about the X-ray and the CCT. Now tell us, do you need a diagnostic DNC to diagnose your GTN?
No, sir.
Why?
Sir, the plateauing of beta HCG only will tell us about the.
That it will. But what is the role of diagnostic DNC in diagnosing GTN?
It can only be done when there is profuse bleeding and beta HCG is on the lower side, less than 1500.
There, the diagnostic DNC can be more dangerous also. So we do not diagnose GTN by DNC, okay?
Yes.
And the reason being that in some types, when it invades the myometrium, like we're talking about the invasive mole and choriocarcinoma, when it invades the myometrium, you cannot take the sample from the myometrium. Okay, so that is why we never do DNC for the diagnosis of GTN. Okay, and very rarely it may so happen that after normal delivery, if you have a abnormal uterine bleeding for diagnosing, you can, but very rarely it happens. You can have a DNC and have a histological diagnosis, but it's very rare. So the diagnosis is mainly on the follow-up of a case of molar pregnancy, isn't it?
Yeah.
With the help of titer. So you must
It is,
still,
I think, only one cancer where we do not give chemotherapy on the basis of histopath. Like even if histopath is not there, with our scoring, we can go for the treatment.
yeah.
So your case was a GTN after a molar evacuation. Okay. So now can you just tell us what are the high risk moles which are more likely to develop persistent GTN? What are those criteria?
Which one is more dangerous? A GTN following a normal delivery, a GTN following an incomplete abortion, or a GTN following a molar pregnancy, like your case?
GTN following a normal delivery is more dangerous.
Okay. Okay, now tell madam what she wants to know.
Divesh, how many types of molar pregnancy are there? Divesh and Pooja?
Right, so a complete mole and a partial mole.
Okay, out of these two again, which is more ominous?
Complete mole.
Complete mole.
Yes, ma'am. Around 15% it is.
So
And which are
complete
those
mole needs a
15%?
longer follow-up, and partial mole, once evacuation is done and the beta HCG comes down to normal, we can leave her alone. But molar needs a continuous follow-up because of the risk of this GTN happening in these cases. Okay. So now since you have already scored her and the score is 3. Okay. So how would you next manage her? What will be your plan of management?
1 minute, Bhagyalakshmi. Before we go into that, we'd like to ask the students, what is PSTT and what is epithelioid tumor?
So these
What are
are the
Yes.
these are the forms of malignant forms of the gestational trophoblastic disease.
PSCT is placental site trophoblastic tumor and ETT is epithelioid trophoblastic tumor, which develops from an extravillous trophoblast. And it is it has a lower, the beta HCG is always on the lower side, and metastasis is late presentation. Metastasis is very late. They are chemo, yes, and they are chemo resistant, more likely chemo resistant,
Why is it so that the beta HCG level is low?
because they are developed from an extravillous trophoblast.
Okay, and the HCG is secreted from the which trophoblast?
Syncytial trophoblast.
Syncytial trophoblast. Okay, but there is one marker for this PSTT and epithelioid tumors. What is that?
What is the marker?
Human placental lactogen, ma'am.
Okay, so would you like to include the HPL estimation in your case here?
Sir, history of molar pregnancy following plateauing, more likely it will go towards a invasive mole or a
So once again, you look at the beta HCG values. If the beta HCG values are high and rising or have a consistent or persistent plateau, then there is no need to exclude PSTT or normally. Okay, as the madam said that we do not depend on histopathology, but only rarely we can have PSTT or epithelioid tumors. So you can go ahead with this. Okay, now I'll come back to the Bhagyalakshmi's question. Now, according to you, it's a low risk. How do you propose to manage this pregnancy, this condition?
The low risk GTN is usually treated with single agent chemotherapy.
What is the chemotherapy we use in our Indian setting?
We use methotrexate, either methotrexate or actinomycin D, ma'am.
What is the commonest, I'm asking?
Methotrexate, 8 days regimen.
So what are the commonest regimen?
You should say that methotrexate is the drug of choice, but in case there are some problems with the methotrexate or there is resistance, then you can go for actinomycin D. It is not either or. Okay.
Yes.
Methotrexate is the primary choice. Yes.
Yes. What is the commonest regimen that we use?
Ma'am, we use ma'am methotrexate, folinic acid, 8 days regimen, ma'am. We give methotrexate 50 milligram, 50 milligram, ma'am, IM on day 1, day 3, day 5, day 7 with folinic acid on day 2, day 4, day 6, and day 8, ma'am.
Is there any role of single agent chemotherapy? Single dose chemotherapy?
Single dose.
Yes. And 50 milligrams per meter square on day one itself, and the
In
following.
the current scenario for beta for GTN, do you think we should give this, or it is for some other condition?
It is for high risk and single
You yourself said this is low risk.
ectopic
Yeah.
pregnancy.
You don't give it for GTNs, no?
Yes.
Yeah.
Ectopic
And so, how many cycles? How will you repeat it? What is the cycling? I mean, after how many days will you repeat the chemotherapy? Until what time will you repeat? How many cycles will you give?
Ma'am, we repeat, ma'am, every 2 weekly, ma'am, until beta CG level normalizes. In low risk patient, ma'am, we will consolidate to, ma'am, 1 to 2 more cycles with chemotherapy.
No, Pooja, just to tell you that that 2 weekly is actually a very confusing thing. People finish and then start the next cycle after 2 weeks. So
Yeah,
if you
day one.
give this chemotherapy for 8 days, what is the gap after which you will start the next cycle?
Day one.
So you
Suppose you
count
give
the
this
2 weeks
cycle for
from there.
8 days, how many days there will be rest and then you start the second cycle?
8 days rest.
Sorry?
Huh?
8 days rest, ma'am.
Then it will
Eight.
not be 6 by 2 weekly, no, because 8 days we are giving the chemo and we are telling that we should repeat it every 2 weeks. So if you give 8 days, it will become 16 days.
The 14 days के लिए, how many days rest? 6 days rest.
So
Six
8
days
days,
rest.
6 days rest.
6
And
days
then
rest.
we come back for the second cycle. So before giving the second cycle, what are the investigations you will need to do?
We will give ma'am CBC, LFT, KFT, thyroid profile, ma'am.
Thyroid
To
profile,
start.
why?
Thyroid profile we don't need to do
Only
every
LFT.
time because if
Only
you have done
Only
it once,
LFT,
it's normally
CBC,
okay.
and urea creatinine.
Yeah. What the most important thing, one which you will do, which will guide your treatment? LFT, RFT, that will do to know whether the patient is fit to give chemo or
क्या
not.
follow कर रहे हैं हम?
What is the most important one which you will do?
And beta CG.
Yes.
Beta.
So that you have to do first. So how you will know that the woman is responding or not responding from the beta HCG value?
Ma'am,
What do you
it
expect?
will
Fall in beta CG level
more than
10%.
more than 50%, ma'am.
More than 50%.
10.
कंफ्यूज मत हो, बहुत क्लियर कट वो है मैथ्स है इसमें. How much beta CG should we fall? So we're thinking that हमारी methotrexate is effective, है ना? You are right. You said one value which was right. बताओ क्या बोला था आपने?
10%.
जोर से बोल.
10%.
Yeah, at least a 10% fall should be there.
10%.
Okay. Yeah, at
One
least
log fall.
1 log fall or more than 10%. Okay, that is what it is.
Anything less than that, then we will give chemo for one more cycle and then maybe change, right? With one cycle also for less fall, we are not changing. So we may change. Okay. So is it necessary to? Yes, sir.
Have they mentioned about the FIGO staging? We have gone into WHO scoring. Have they mentioned FIGO staging?
FIGO scoring, yes.
What is the stage?
Stage 3, ma'am.
Why do you say that?
FIGO stage 3, because there is a lung nodule which was
Lung nodule.
significant in size, 1 into 1 centimeter.
So apart from the genital tract, you have a lung involvement. So it is stage 3. But according to WHO scoring, it is low risk, isn't it?
Yes. Yes.
Okay. Move ahead now. What else to do now?
So what are the complications that you can expect, Divesh and Pooja, when you are giving methotrexate?
Ma'am, firstly, LFTs can be deranged, one thing, because the methotrexate is hepatotoxic. toxic. Then there might be mucositis, which can be very painful and affect the nutrition of the patient. Then at even higher doses, there might be bone marrow suppression. So these three
Yeah.
things.
Dose, हाँ, yeah. Dose तो आपकी वही है जो आप दे रहे हो. In subsequent cycles, there can be myelosuppression. So what do you do if there is a decrease in the total leukopenia? What will you do?
GCM, GCFM stimulators. Granulocyte colony forming stimulator drug.
Yeah, okay.
नाम नहीं बोल
ठीक है.
And during chemotherapy, can you expect more vaginal bleeding? Yeah, you should expect and tell the patient accordingly, also counsel her, because the tissue sometimes get loose and start shedding, and sometimes she may get profuse bleeding also during chemotherapy. So she has to be a little careful about that. Okay, so I think you have given 3 cycles, then the beta HCG has become normal. Then what you will do?
What was the regime they have used? Immaculate regime or
Which
which
regimen?
Methotrexate.
Methotrexate acid, yes.
Okay.
So how do you, so if after 3 cycles it has become normal, then what do you do? You leave her alone or
We will follow with the beta HCG for weekly for 3 weeks, then monthly for
1 year.
1
no,
year.
no, Devesh, please get me. You are not getting me. You have given 3 cycles of chemotherapy. Beta HCG has become normal. So do we keep her under follow-up or give some more cycles called consolidation therapy?
Ma'am, we will give ma'am
1 to
1
2
cycles.
more, or and we will follow up with beta HCG.
Yes. Even after it becomes negative, we have to give chemotherapy. And then why is that?
Ma'am, to decrease the ma'am relapse in future, ma'am, because ma'am in low risk cases there is a 2% chance of ma'am relapse.
Do you think after the beta HCG has become normal also, there are some cells which are still lurking in the body? The beta HCG are not picked up and they appear to be, the blood tests appear to be normal.
Yes, ma'am.
Yes. So
Yes,
there
ma'am.
are some cells which are still there. We are not able to detect. So that's why we are giving consolidation more 1 or 2 cycles. Ideally, it's 2 cycles. For low risk also, we give 2 more cycles. So 2 cycles are finished. She's still normal. Then what do you do?
Then we'll follow with weekly beta HCG reports for initial 3 weeks, then monthly for the next 1 week. And we will advise
To get
contraception for the patient.
What contraception?
Either ma'am oral contraceptive or variant methods, ma'am.
Or
Oral
barrier?
contraceptive.
I think
Variant
oral
methods.
contraceptives are safer than
Safer,
barrier.
safer.
Okay. So when will you allow pregnancy?
Why? Let them reply. Why the oral contraceptive is favored? Once upon a time, we used to say that the oral contraceptive should not be given, right? And now we are saying that it should be given. Ideal. Why? What is the commonest type of oral contraceptive pill that is used these days? And what is the failure rate of the barrier contraceptive? These 2 questions are related in the case of follow-up of GTN. Bhagya, I'm a bit confused. You said that she has a score of 3, isn't it? That means she's
Yes,
a
sir.
low risk,
Low
right?
risk.
Less than 6. And why can't we go for single agent chemotherapy in this case?
So methotrexate, they're giving single
No,
agent.
sir is asking about single dose, I think. Sir, once a patient needs chemotherapy, I think cycles are better, because when we are giving single dose, that could be prophylactic only when we are doing the molar evacuation.
Molar pregnancy, yes, that's
Yes,
right.
yes.
So
But the
studies have shown better results with the cyclical chemotherapy regimens.
no, but single agent is okay. But you are saying that what is the point that they should move into the other regimes like etoposide or other agents, the combined regimes?
No, not
high
in
risk.
this case,
Only for
not
high
this,
risk.
only high
Only
risk.
for high risk, isn't it?
High
That
risk,
is
yes.
above 7, isn't it?
Yes, more than 7.
More than 7.
So agent should be single, but the cycle should be, as you said. So you prefer to have 2 consecutive negatives or 3 consecutive negatives? Bit ICG.
After 1 negative, we give 2 more cycles, sir.
Okay. Okay, now the patient is now discharged. You have discharged the patient now, right? Isn't it?
Yes, sir.
Okay.
Yes.
Advice. What advice? We have talked about contraception. We have about 7 minutes left now for the case presentation. What are the other advice that you will be giving her? What about indications for recurrence or follow up? How long will you keep the patient on hold for pregnancy?
We will counsel the patient that to use oral contraceptives, OC pills, like combined estrogen and progesterone pills, and will tell the patient that the barrier methods have a failure rate of 20 to 30%. So we will counsel her on that, and we will teach her about the symptoms of recurrence, like profuse vaginal bleeding, or if
Hmm.
there.
Divesh, but we have to tell her to do her beta HCG regularly, no?
Yes,
So if
yes,
she is
ma'am.
in a remote village where beta HCG is not possible, what else we can advise her?
Urine pregnancy
Yes,
kits can
Yeah.
at least that minimum test she can do regularly and get back to you once suppose it gets positive. So she has been under regular follow-up. She has come back after suppose 8 months with a urine pregnancy test positive report. So what will be your next line of management?
to quantify the beta HCG, blood beta HCG value at that point, and we will have to do a scan, a pelvic exam, a complete profile, a pelvic examination, uh, at least a TVS scan to look for the growth, and a chest X-ray.
What will be your first diagnosis? She has come back after 8 months.
First, follow pregnancy, new
Yes.
pregnancy.
Yeah, ask her now whether she is using contraception, failure of
Yes.
contraception.
Yes.
Okay. And so whenever if suppose she is not a pregnancy, she's again relapsed after on your follow-up. So in that case, again, as you rightly said, you have to restage the patient, do the entire workup again, do a chest X-ray, do an ultrasound abdomen, do an ultrasound, so to see where is now the focus of the disease. So now what will you do? As ma'am said, now pregnancy is, UPT is positive, beta HCG now say 50,000. So what will you do now?
50,000. We will
Only one
first
value is 50,000. So now what will you do?
repeat beta HCG after 1 week.
Yeah, you have to repeat. At least we should have 2 values of rise or 3 values of plateau to call it a chemoresistance or something. Okay. I mean, not chemoresistance, or recurrence. Okay. So now suppose she is what is the just for now, because as a postgraduate, just tell us what will you do. Suppose now the second line chemotherapy in this case once she is recurred.
Actinomycin D, pulse therapy, or single day therapy. Actinomycin D is the second line of drug.
Divish, I think when she comes back to you with a recurrence, we will
Yeah.
score her again.
Yes.
And stage her again. So if she's still in the low risk group, then we will think about actinomycin D. If she has gone to the high risk or the group, then we will surely go over to the multi-drug regimen.
Or etoposide, yes. So
So each time she comes back, if she has a recurrence, we have to rescore. So it's called a dynamic scoring. Each time pre-treatment scoring has to be done.
That is why you do a complete workup again. Okay.
Yeah. And Pooja, Divesh and Pooja, can you tell us what are the indications of hysterectomy in such type of case that you have?
The hysterectomy can be done if the patient is experiencing excessive vaginal bleeding, or it can be done, sir, in older women in which fertility is not concerned.
Fertility is not concerned. Okay, fertility is not life is always a concern. But is a failed chemotherapy is an indication for hysterectomy, like this case you have just mentioned?
No, sir.
Not a-
Yes. Yes.
Okay. So in cases like PSTT, we always go for hysterectomy because
Yes, sir.
because they are not more sensitive, and of course, family is a concern. But intractable bleeding, yes, one of the indications. But always remember that this always after hysterectomy, also the patient needs as good follow-up
Okay, sir.
like we used to do with ICG. So hysterectomy doesn't stop you from doing a follow-up. Same follow-up regime has to be followed. Okay.
Suppose this woman had a theca lutein cyst, okay? So how do you, what do you have? Do you have to do any intervention of the theca lutein cysts?
Ma'am, it usually regress, ma'am, after 2 to 4 months after evacuation.
Yes. And even on chemotherapy, they also regress. So no active intervention has to be done regarding that, okay?
Yes.
And Devesh, one of your DD was arteriovenous malformation, right?
Yes, ma'am.
So what is the imaging finding in a AV malformation and how do you manage?
Now, the imaging finding will be, and suppose if there is a increased vascularity in the TVS, in the myometrium only, and we can do an MRI to confirm it, and management will be also we can do a Doppler to check the and management will be coiling of the uterine arteries, interventional radiology.
Yes. Good. I think Dr. Sunesh sir has come. He has some comments, sir.
I think beautiful presentation, beautiful discussion. Over years, what changes I saw in the management of such cases at Institute Rotary Cancer Hospital AIMS, I'll just highlight those. Initially, it is true, after last SCG became negative, we were giving 3 more chemo. But since SCG has become now so sensitive, when 3 values are negative, we don't give any further chemotherapy, rather keep her on follow-up. Second is contraception. Earlier, we used to say avoid pregnancy for 2 years, 1 year. Now it is 6 months since the last SCG became negative. They can plan pregnancy. Another thing I would like to mention about is CT chest. Earlier, we used to limit only to patients where we were suspecting strongly lung metastasis. Now, in addition to chest X-ray, it is a kind of routine to do CT chest, HRCT, and that will pick up many cases where small disease in the lungs. So over time, things are changing. Coming to single dose methotrexate, actually this concept initially came for patient who had advanced disease, stage 4 disease, and had brain metastasis. We used to dissolve 300 milligram methotrexate in a drip and give it over 24 hours. I've done personally myself for such patient, but giving single dose of 50 milligram to avoid GTN is no longer now practice. So giving methotrexate on day 1, 3, 5, and 7, and leucovorin on day 2, 4, 6, 8 is the standard way of giving chemotherapy. Common side effect with methotrexate, of course, is liver function dysfunction, and you may have to often change to the other drugs. But I think good case for discussion, and it depends upon, over here we have seen decreasing number of such patient coming to hospital. In fact, I was talking to someone from south of India. They say they hardly see GTN there. Here
It's
in
mainly in
northern
the Asian
India,
countries. Yes, sir.
yes.
We are getting GTN. Sir, one of my medical oncologist friends said that they are now switching over to actinomycin D more as a single agent chemotherapy than the methotrexate. So, what is your take on?
It is, I think, personal choice, probably his personal choice. But methotrexate still remains first line drug, only with the guard that it may cause liver dysfunction. Actinomycin D is so simple to give. I personally have given patient, we give 1 microgram per kg daily for 5 days. With methotrexate, it will go on for 8
Muktada,
or 9 days.
the only issue with actinomycin D is it is a little more toxic than methotrexate. And
Yes.
if there is a little extravasation, that's a big issue.
Yeah.
So I think for Indian population, as we know, most of our centers still we practice methotrexate. And if she becomes resistant and still comes back as a low score, then we may change to actinomycin D.
Main problem with the actinomycin is vomiting. So in fact,
Yes,
I
sir.
remember before pushing actinomycin D IV, we used to give antiemetic IV and then push the actinomycin D. It was so simple to give. Patient comes, put in a Venflon and just push, and she can go home after 15 minutes.
Thank you very much. I think we are coming to the closing time now gradually. Before parting, we will just like to ask the students any idea they have about the prognosis of this condition. What is the cure rate in your low risk or GTN or HMOL, whatever you say, gestational trophoblastic disease, what is the prognosis like?
Sir, prognosis is very good. There is approximately 100% cure rate.
In all, in everybody, or
Yeah. So I think Divesh, for you all to make it simple, that 20% of mole will develop into GTN. 20% of the GTN will will have high risk. So 20, 20, 20, you remember. So always there will be a chemo resistance in 20% of them. And 20% will become present as high risk later. 20% will have chemo resistance. And then 20% will sometimes never respond at all sometimes and become.
And this 100% is good for, up to the choriocarcinoma or even non-metastatic lesions. In cases of metastasis, the prognosis are slightly altered. It is 90-95% range. It is not 100%. Okay, so I will close it over here because we had a lot of discussion on this case. Thank you very much for all the faculty members for this very good interaction and some opinion and comments from Dr. Sunesh Kumar, now Dr. Bindya Gupta, Dr. Bhagya Lakshmi Nayak, and all both the students. They have done wonderfully well. Thank you very much. I'd like to close.
Do they know who is FOGSI?
Which?
Backshaw.
Backshaw. Okay.
So his regimen we still follow.
Yeah.
Have you heard his name?
Yeah, I think sir, food for thought. So they'll go back and read about him.
Yes, agreed.
They don't know the names of their HODs sometimes. So, okay, sir. Thank you very much. And I will close it over here and proceed to the next session. Hafizur, are you there?
Thank you, sir.
Thank you.
Thank you, sir. Thank you, Bhagya Lakshmi ma'am. Thank you.
Thank you so
Thank
much.
you.
Please. Students, please stop.
And Divesh and Pooja, hope it was a good experience for both of you.
Well done.
And food for thought and studies going back home.
Yeah. Please read it again. I think you'll actually pick up many more points after this discussion.
Correct.
Thank you so much.
Thank you so
Thank you so much, sir.
Okay. So stay tuned because we are coming up with another interesting session, which will be taken up by yours truly. I will go for this. Traditionally, we have been always focusing on the diaphyseal pelvis, and you know that in PG examination, you have separate marks for this, which is known as the diaphyseal pelvis. Okay. Now, for the first time in ICOG, we are going to have a discussion on fetal head only. That means giving importance to the fetal head. Just let me get the head. Okay. Yes. One minute. Now, can you see this? Bakshi. Down the right side. Okay, can you see this all, please? Hello?
Yes, sir, visible.
Okay. Okay, I'd like to have a focus on this because this is going to hold the center stage for some time now. So now we are going to discuss the fetal head in its different aspects and the clinical importance. First of all, in the exam, you are always actually given in pairs. That means head and the pelvis. So you should have develop the habit of holding the pelvis in one hand like this in the anatomical position and hold the head like this. Okay, and you are ready for a presentation normally. But how to hold the head in exam is a very important question. Could you have a spotlight on this? Hello, Yogita.
Yes, sir.
Can you have a spotlight on this head so that it is visible in through the entire screen?
Yes, sir.
Okay. So whenever you get this head in examination, my suggestions to the students, please put your index finger inside the foramen magnum like this. This is a very important tip because otherwise, if you do not hold the head by passing a fingertip inside the foramen magnum, you will possibly hold in all different directions and wrong directions. So put your finger in the foramen magnum, then you rotate the head below your hand. Whenever you find some rough surfaces, you fix this head and make it like this. So with the pelvis, it will become like this. What is this? Why we're insisting that you should hold the head like this? Because if you see the head, this is the part which is the most important part in cephalic presentation. This is known as the occiput or external occipital protuberance. This should be lower. And the opposite part is the sinciput or the brow area. So this should be remain high. When it is so, we call it a flexed position of the head. As the head goes inside the pelvis, it becomes more and more flexed. And ultimately, the chin actually touches this is the chest wall of the fetus. So you have to hold the head like this during examination to maintain flex position. What are the other positions apart from flex position? If you look at this, when the occiput and sinciput are in the same plane, we call it deflexed head. Deflexed head has got many disadvantages because it will assume more place, more diameter, bigger diameter will go inside the pelvis. So if you look at the pelvis, the engaging diameter of the fetal head is suboccipitobregmatic, which means what? This is the area of subocciput and this is the bregma. I'll come to bregma in a few minutes. The suboccipitobregmatic, or this is the lowest possible diameter of the fetal head, that is 9.5 centimeter. In the transverse direction, the diameter is biparietal diameter between the two parietal eminences, and we call it the lowest possible transverse diameter. There are other transverse diameters like bimastoid and bitemporal diameters of not of much significance, but you should remember these two diameters. Suboccipitobregmatic is this diameter, 9.5, and suboccipito and biparietal. So it is the plane, the suboccipitobregmatico-biparietal plane, which negotiates the plane of inlet, and we call it engagement. That's the first mechanism of labor. Now we come back from the labor, and we see how many parts of this bony parts are there in the fetal skull vault. You see, you have got two parietal bones, two frontal bones, two temporal bones, and one occipital bone. And they are united by sutures. What are sutures? They're membranous structures which are going through different gaps. And the condensation of these membranous gaps are called fontanelles. So how many fontanelles we have? We have 6 fontanelles, but for obstetric importance, we have only 2 which are very important. One is the anteriorly, that is the diamond-shaped 3 into 3 centimeter anterior fontanelle, also called bregma. And posteriorly, we have Y-shaped, the posterior fontanelle or lambda. So these 2 fontanelles are of importance in obstetrics, particularly in labor. So what are the major bones we have discussed? We have sutures and fontanelles. Now, what are the sutures? These are the fontanelles. Sutures are this. This is called the sagittal suture in the midline. This is the sagittal suture in the midline. This is the frontal suture, also called the metopic suture in the midline. This one, from the anterior fontanelle, it runs down up to the root of the nose or nasion. And this part, from this point onwards, the phase starts. Phase starts from the root of the nose or nasion. From there, it goes up to the chin. But when the diameters we take the junction of the floor of the mouth and the neck. That is the basic difference in the diameters. Now I will come to the diameters. So after the sutures, we'll come to the diameters. As I said, suboccipitobregmatic is the shortest possible diameter in the cephalic vertex. Then the next diameter, it becomes slightly deflexed. The subocciput point moves towards the, remains at the same place, but the anterior point comes to the anterior end of the anterior fontanelle. So from the center of the bregma, this point moves towards the anterior end of the anterior fontanelle. And this happened because the head is slightly deflexed. So that diameter is suboccipitofrontal, which is 10 centimeters. Okay. So from 9.5 centimeters suboccipitobregmatic, we move on to suboccipitofrontal 10 centimeters. Where do you get this diameter? You get this diameter in at least two conditions. One is the occipitoposterior position of the fetal head, that is malposition of the fetal head. And the second is the aftercoming head of the bridge. Both these places, complete flexion of the head is not possible, and therefore suboccipitobregmatic is not possible. Okay. So we have suboccipitofrontal. Now suppose there is more deflection like this. Then what happens? The posterior point shifts here to the occiput or external occipital protuberance, and the anterior point moves up to the root of the nose or nasion. This is called occipitofrontal, 11.5 centimeter, much larger diameter. So from the simple, from the flexion to the deflection, we have different diameters, and you can understand now the deflection is more dangerous for the baby to go inside. Not dangerous, it is disadvantageous for the head to go in, because the bigger diameters have to go. Now 11.5 centimeter have to go. Now suppose there is further deflection of the head like this. That means now the occiput goes up and the sinciput comes down. As I said, normalcy is when the occiput is down and sinciput is up. But here occiput is up and the sinciput is down. Now this is called the classical brow presentation. What is the diameter in brow presentation? You can see this is the mentum from up to the highest point of the sagittal suture. This is the diameter which is known as the mento-vertical diameter. Mento-vertical diameter is 14 centimeter, and there is no diameter in the pelvis which would accommodate this 14 centimeter diameter of the head, and therefore no mechanism of labor is possible for brow presentation. Unless, of course, it's a multigravida and it converts into either a flexion or a extension. When it goes into extension, it becomes a face presentation. In face presentation, what happens? Now this is fully extended head, and the diameters are submentobregmatic. Submentobregmatic means from the junction of the floor of the mouth and the neck up to the center of the bregma. So this diameter is once again, this is 9.5 centimeter, along with biparatal diameter, which is 9.5. So this submentobregmatic and biparatal, they become, but biparatal of course comes much later, but the submentobregmatic is 9.5 centimeter. Now one can argue that if it is submentobregmatic, 9.5 centimeter, suboccipitobregmatic is also 9.5 centimeter, then why do you call face a malpresentation? You remember that face is usually called a malpresentation. Why? Because normal labor is not possible normally not possible in cases of face presentation. What happens? Because there are uneven surfaces which doesn't act like a good dilator, and also there is a tendency of rupture of the membranes, and also there are movements problem It happens particularly in different types of pelvis, contracted type of pelvis. So face is known as the malpresentation. Now the diameters are submentopragmatic, 9.5 centimeter, and the mechanism of labor is also different. We'll discuss some other day. So these are the different aspects of the head, starting from the full flexion, up to mild deflection, moderate deflection, severe deflection, and then full extension. So this movement is very, very important. Now, occiput and sinciput I have already described. Now, another thing is that what are the diameters I have already mentioned. What is now the mechanism of labor, diameter of engagement, etc., etc. So all the diameters you should remember. One is suboccipital-pragmatic, one is suboccipital-frontal, then occipito-frontal, then mento-vertical, then submento-vertical, and then submento-pragmatic finally. And accordingly, the attitude will be fully flexed, partly deflexed, or completely extended. So that is about the fetal head conditions which we need to meet in labor. Okay. Now, in exam also we get the questions like, describe what to mean by vortex. Now, vortex is actually a quadrangular area. Vortex is actually a quadrangular area. You should hold like this. Quadrangular area bounded anteriorly by the bregma. This is the bregma, diamond-shaped. Bregma and the coronal sutures. This is the coronal suture. Bregma and the coronal sutures. Posteriorly by the lambda and the lambdoid sutures. Okay. Lambda and the lambda. This is the lambda Y-shaped, as I said, and these are the lambdoid sutures. And laterally by the lines passing through the parietal eminences. So you hold the hand like this. So your thumb will be on the lambdoid suture, both the thumbs, and anteriorly the two index fingers will be on the bregma or anterior frontally. This quadrangular area is known as the vortex. It is actually a presenting part. So it's a presenting part of the presentation called cephalic presentation. Incidentally, cephalic presentation is almost 97%, and Baki are malpresentations. And of this thing, maximum is the vortex presentation. We call it a vortex presentation. Actually, it is a vortex is the presenting part. So when this part of the head presents at the lower pole, we call it a vortex presentation. Actually, vortex is the presenting part. So that is about the presentation. Now, what is the, we have discussed about almost all the diameters of the head. Now, come to the two phenomena in labor I must mention. One is the caput succedaneum, another is the molding. I'll take up molding first. What is molding? Molding, as you can see, when you examine the bones carefully, you will see there are gaps in the membranes and the gaps in the bones also. Gaps in the bones are all called the fontanelli, and gaps in the sutures are widely separated. Particularly in premature babies, they are very widely separated. Now, why is this so? This is because it has to encourage the brain growth inside the protective skull. Okay. Now, while doing so, while going into the pelvis like this, it has got a girdle of contact with the bony pelvic parts. And on this girdle of contact, suppose the girdle of contact is this, areas on which the areas of the fetal head which touches the pelvis, what happens? There is compression at this level. So because of this compression at this level, you imagine this is the pelvis, it is going inside the pelvis, the head is being compressed. And because of this compression at one plane, what happens? The head or the bones with the sutures, they tend to elongate at the opposite angle, opposite axis. That means if the compression is here, the elongation will be in this axis. If the compression is in the suboccipito-bregmatic level, the elongation will be on the mento-vertical level. This is called molding. That means changing the shape of the fetal head in order to decrease the attempt is to decrease the diameters of the presentation. So that is an honest effort by the nature, to accommodate the fetal head inside the pelvis. Now there is an upper limit. You must argue that so much of compression is not good for the fetal brain, and there can be fetal cerebral hypoxia, anoxia, maybe injury also, tear of the tentorium cerebellar, etc. All these things happen. So there is a safe range for molding, and that safe range is 4 millimeter. If it goes beyond 4 millimeter, we call it overmolding or super molding, and that may cause intracranial injuries or problems. So this molding actually allows, molding is a friendly thing which will allow the obstetrician to ensure vaginal delivery, good vaginal delivery, safe vaginal delivery, but one must be on the caution that excessive molding is bad. So how do you understand this molding, excessive or not? So there is a grading of molding. We call it 1+, 2+, 3+, etc. 1+ means these sutures that you can see, they are opposed to each other. This is called 1+ molding. When the bones, they tend to overlap, but they can be separated, easily separated. That is grade 2 molding. When they are superimposing on each other, but it's difficult to separate, then it is high time that you should not allow any more compression of this fetal head, and then take out the baby by an alternate means. So that is called severe degree of molding. So this molding, actually, it's a beneficial attempt by the nature to deliver the head. But if the obstruction is continuing, or there is a fault in the passage, then you should stop it there, diagnose it there, and take out the baby. So that is the importance of molding. So molding you can understand by the slipping of the one bone over the other. Usually we take the parietal bones over each other because they are most spread out bone and they can be easily palpated. So this is called molding. Second condition is caput succedaneum. Caput succedaneum is simply because of this compression over here and the alteration in the venous return. So what happens, there is venous and lymph returns. What happens, there is a collection of fluid in the layers of the scalp. So this is called caput succedaneum. Caput is a localized phenomenon. It happens distal to the area of compression. So the proximal part is not affected. Proximal part unaffected, the distal part is affected. That means where the compression is there, only that area, the caput succedaneum will be there. Now, what is the importance of caput? Is it good or bad? First of all, anything excessive is bad. So excessive caput is bad, but caput in the small, this thing will be indication of the position of the occiput and position of the sinciput and the fetal, position or the relationship with the different quadrants of the female pelvis. So I think the caput succedaneum it also helps in the identification of the flex condition or extended condition of the fetal head. What is the difference between caput succedaneum and cephal hematoma? Well, cephal hematoma is the bleeding which happens inside the layers, and that happens usually following an injury or elongation, strong elongation, or there is some form of trauma. So therefore, I think that caput is going to go away within a few hours after birth, but cephal hematoma will take more time. Usually it takes 2 weeks or more for disappearance of the cephal hematoma, which usually follows by instrumental vaginal delivery. So I think that it should be more. Caput succedaneum is limited by the sutures, but the cephal hematoma is not. It can be across the sutures, and it is quite so. It is very, very important to differentiate between the cephal hematoma and the caput succedaneum. Okay, so we have finished about molding. We have finished about caput succedaneum and etc. Now some basic questions about this internal rotation and restitution, etc. We'll just describe, because this head, as I said, this leading pole, that is the occiput, which is incidentally the denominator of the cephalic, the vertex presenting part. This is the vertex. So this is the occiput, which is the leading pole. It actually touches the pelvic floor like this. pelvic floor like this. So fully flexed head will touch the pelvic floor and it initiates the internal rotation. This is the internal rotation that happens at the level of the lever tendon muscle. So occiput plays a great role in the internal rotation. Now, another role that the occiput and subocciput they play is hinging. This hinging happens just behind the symphysis pubis like this. This hinging is important because unless and until the subocciput is hinged here, the head cannot move by extension like this. Extension like this. So I think that this occiput and the subocciput play a very crucial role in the taking out of the delivery of the head. Now, another important role is of the aftercoming head of the breech. When you palpate the subocciput, like Dr. Sunesh Kumar was showing in his presentation, after coming to the breech forceps delivery, when to put the forceps in, you have to palpate the suboccipital area. Unless and until you cannot palpate the suboccipital area, you cannot put the, or also you cannot start the Barn Marshall technique of taking out the baby. So that palpation is very, very crucial. Now, lastly, I will go through some other points which are important from the head point of view, like internal rotation I have covered, like movement of the head, delivery of the head, etc. I will go for the two more mechanisms, which is the synclitism and asynclitism. What is synclitism? You see, look at this sagittal suture. This is the sagittal suture. It usually stays in the midline. Okay. But when the sagittal suture goes forward or backward, this is called asynclitism. Head is usually in the process of asynclitism in 70% of cases. Now, what happens in a multigravida, multiparous woman? There is a pendulous abdomen like this in front of you. And so the head tends to do like this, you know. That means the head gets slightly flattened towards the abdomen. So what happens? This is the posterior parietal bone. Anterior parietal bone, which is presenting over here. Okay. And the suture goes forward, backward. The suture moves backward, anterior parietal presentation, and the suture moves backward. This is known as the posterior asynclitism or anterior parietal presentation. Anterior parietal bone presentation, posterior asynclitism. And this in case of primigravida, because tight abdominal wall, what happens? The head is continuously forced backwards like this. So the posterior parietal bone is presenting like this, and there is anterior shift of the sagittal suture. So that is called anterior asynclitism. So asynclitism is nothing but an attempt by the body in order to negotiate the pelvis like this, any possible ways it can. This is called asynclitism, okay, for engagement of the head. Internal rotation, all of you know that internal rotation happens because of the prick by the bony presenting part, that means the occiput, and it goes there, it irritates that the pelvic floor muscle, and then it rotates through 1/8 of a circle anteriorly to bring the subocciput under the symphysis pubis, and then delivery of the head occurs by the process of extension. Okay, that was demonstrated by the forceps delivery by Dr. Sunesh Kumar. So I think that I will stop here and encourage questions or comments on this. Anything that you want to know about the fetal head only. But remember, always in examination, you will get this fetal head. Always put your finger in the foramen magnum. This like this, and hold the head like this. Much like a spinner holds the ball, like this. But ensure that the rough part of the fetal head, when the fetal face, is actually scratching your palm. In exam, it may be difficult because in exam tension, you may think that these are foramen magnum also. But actually, the finger where it goes through and through, that's a true foramen magnum. Baki all are pseudo. Okay, so this is the position of the head that you should hold in examination while you are asked to demonstrate the normal level. This is called LOA position of the fetal head, and then you move like this. So remember to hold the pelvis in one hand hold the head in one hand, and go inside like this, engagement, show engagement and mechanism of labor. Thank you very much. I think I'll stop here and I will look for questions and comments in the chat box. Hello? Hello? Is there any comments or any questions?
No, sir, right now, no any question.
Okay. Then we will go for the last part of our program, that is the quiz program. Now, I would like to call upon Archana. Are you here, Archana? Dr. Archana Kumari, are you there? I think she hasn't reached yet, isn't it?
Sir, I'm here. Just I'm trying
She joined the
trying to log in. Good afternoon, everyone. So we are going to start soon our Kahoot quiz, and myself with Dr. Bhavna Tiwari is all set to conduct the quiz. I'll be sharing the screen soon.
Yeah, we have 5 minutes time for discussion. Any questions, any comments from any faculty members? Dr. Mukta Agarwal is here. Dr. Divesh is there. Sorry, there's Dr. Shayanti is here. And Dr. Bindia is there. Any question or any comments? You are highly welcome to put some any question, or you want to discuss something else with the students. That is also welcome. Dr. Mukta Agarwal would like.
It's a very nice presentation, sir. Hello, sir. Sir, it was a wonderful session, sir. Actually, I could remember my PG days when we used to rush to listen to your classes on dummy pelvis and fetus.
Yeah. Thank you, Sayanti.
Thank you.
Dr. Mukta Agarwal, we have some time, 5 minutes for discussion, and we are constantly looking at the chat box.
Yes, sir. There is one question in the chat box, sir. Subgaleal hematoma, please explain. It's from Siva.
This is a kind of intracranial hemorrhage which happens usually following a forceps or a venous delivery, and it's like we talked about cephal hematoma. It is almost like that, but yes, subgaleal hematoma is much more serious in its nature. But I think that it to be regarded as a complication of the forceps or venous delivery, instrumental delivery.
Thank you, sir. And today, even we have just recapitulated all the forceps because applying those Keelan forceps and all. So practically, we are not doing the manual rotation, forceps extraction, and Keelan's forceps. So it was a very nice experience, and we all are glued onto our screens.
Yes, that brought back the memory of, I think I haven't seen anyone applying Keelan's forceps for a long, long time now. Maybe in my student days I used to see. After that, I haven't seen.
Yes, sir. We have just seen Keelan's forceps in those instrument tray, but we have not applied Keelan's.
Nowadays, we have removed that also from the instrument tray.
Yes, sir.
I mean, the tray is there, but the forceps is not there.
Forceps are not there. Yes, sir.
Yes, sir. So, and so I would like to make a comment on your presentation, the way you taught. It was absolutely fantastic because, when we teach fetus as it's basically confined to anatomy and, there's some amount of caput succedaneum and that is it. But the way you said that if it is stuck here, it will be, the caput will form here. So that location of the caput, after a long, long time, I've heard somebody talking such practical obstetrics and such a very small topic of fetus was made such so beautifully. So you've taught. I think it was a pleasure and treat to hear for you also.
Thank you, Dr. Kunja. Thank you. Thank you. And I wish that Dr. Sunesh Kumar would have been here to interact some of the question of because he didn't have time to discuss about the complications of all sorts of venous delivery. I think that is also that's a major concern in patients' minds. That's a problem.
Even as practicing obstetrician, the art of instrumental delivery, it's vanishing. Maybe because of the complication or because of the fear of litigations.
Correct.
Because the normal delivery is always a retrospective diagnosis.
Patients cannot take instrumental delivery very, very lightly or seriously. They cannot take it. Just say they cannot accept it. Somehow it is ingrained in their mind that it should be avoided. Why should you do this? Why my baby only? So they say like that. Even episiotomy these days they tend to object.
Yeah.
Yesterday's women were prepared differently mentally during labor. That yes, they need to cut open the door of this thing labor so that the baby's delivery happens smoothly. But hardly I find women who are willing to undergo vaginal delivery these days, even.
And it's especially true for the affluent classes, even for the doctors. It's difficult to counsel for the normal delivery than for they are more inclined towards the cesarean sections.
Yeah, correct. Maybe we are also partly responsible for that. We have showed them that the cesarean section is very safe. They have also started thinking that the cesarean section is the safest possible way of delivering the baby. So, if you do not have anything else to interact, then I will call back in Archana.
Yeah, good afternoon, sir. I will share my screen and is my screen visible?
Not yet. Now it is visible.
Yes, ma'am.
It's visible, no?
Yeah.
So I hope all the quiz participants are able to see the game pin. And let us see who all joined. The participants, you need to enter into kahoot.it and enter the game pin. And please enter your proper name, like Divesh is okay. But I don't understand MAH. Please write your name properly so that we are able to identify you. Yeah, so let us wait for the...
We have to think about this privacy and confidentiality business, Archana, I think. Because in almost all the quiz programs, I am seeing that nobody is trying to disclose their original names.
Their original identity, unless they win.
I know. Forget about the complicated and long names like mine, Ashish Kumar Mukhopadhyay. They're now not even writing in the name like Ashish or Payal or Somya. We are lucky to have a few one here. But up to last program, I haven't seen anybody putting their actual name. Somebody has put the name as guess who also. Not in this one, not today,
Yes.
but some other.
$27 participants. We'll wait till 50 at least. Dr. Bhavna, you will start first 10 questions, then myself first 10, and then last 10 will be done by you. Is it okay?
Yes, ma'am. First 10 by me, ma'am.
First 10 by you.
Okay. Fine.
So we have reached 32 participants, waiting for some more EGs to log in. One has logged in as yes. So I hope everybody knows about today's topic. It is gestational trophoblastic neoplasia. So mostly today's question will be more like a theory questions. We have not put any case-based questions, but yes, it would be interesting. I think, shall we start, sir, Asif sir, with your permission? Bhavna, are you ready? Shall we start? I think
Yes,
we are
ma'am.
not, there is no increase in the number of participants. It has
Fine.
reached almost 40.
Yes.
So we can start.
Yes, ma'am.
Okay. So here we start the quiz. Yes, Bhavna, you can start.
So which is the of the following is a feature of complete mole but not partial mole? Options are presence of fetal part, diffuse trophoblastic proliferation, triploid karyotype, and less markedly elevated beta HCG levels. We have already received 10 of 10 answers. Others, hurry up. Which is a feature of complete mole but not partial mole? A easy one.
Yeah, easy one.
So most of you have got it right. Diffuse trophoblastic proliferation is in complete mole. Still few have, seven have got it correct. Many of
Only
you have
7
answered it wrongly.
actually. This was an easy
But
one.
this was an easy one. Diffuse trophoblastic
Yeah.
proliferation is found in complete mole, not partial mole.
Okay, next question. Before that, next maybe have there's a scoreboard. Yeah.
Shrishti is leading, closely followed by AR. AR. So we'll go to the next question. Which of the following is true about invasive mole? It cannot metastasize. It arises only after term pregnancy. It can penetrate the myometrium and it is usually triploid. Invasive mole. 5 seconds still left. Already received 21 answers. Others. So here we end. The answer is it can penetrate the myometrium and 9 of you got it correct. So invasive mole means it can penetrate. It has the power of penetrating the myometrium. So let's move to the next question. Again, Shrishti is leading the scoreboard and closely followed. Now Pooja Yadav is come in the second position. So it will keep on changing till the end. Let's see. According to FIGO scoring, which factors contribute the highest individual score in risk stratification for GTN? So options are interval since antecedent pregnancy more than 12 months, presence of lung metastasis, brain metastasis, and beta HCG levels more than 1 lakh. Highest score, risk score. The correct answer is brain metastasis and only 5 of you got it correct. Many of you have not yet attempted. I can find only...
I don't know why they are not attempting. Is there some login
only
issue?
few of them are attempting, however. So now Pooja Yadav is on the top list in the scoreboard, followed by Devesh, and let's go. So let's go to the next question. According to FIGO WHO scoring, a patient with post-molar GTN is considered low risk if the total score is 0 to 4, 0 to 5, 5 to 6, or 7 to 10. Low score in for molar GTN. Low risk. 18 answers. Out of 40 participants, I suppose, only 20 or 19 are answering, ma'am.
Yeah, I don't know why. Maybe they
No, ma'am, they have logged in but not answering. So the correct answer is 0 to 4, and 6 of you got it correct. So the low risk is considered when the score is 0 to 4. Still, Pooja is taking a lead. So we'll move to the fifth question. In the management of placental cytoplastic tumor, the first line treatment is single agent methotrexate, multi-agent imacotherapy, total abdominal hysterectomy, or high dose actinomycin D. Which of these chemotherapy you will use, or you will go for total abdominal hysterectomy? What is your choice? What is recommended actually? The correct answer is total abdominal hysterectomy, and 8 of you got it correct. In case of PSTT, we don't go for chemotherapy. It is recommended that you go for surgery. So Pooja is still leading the scoreboard, followed by Let's Go, and then Srishti, closely followed by Devesh.
Let's go. We will find.
Which of the following beta HCG trend most accurately indicates post-molar GTN per FIGO criteria? Decline of more than 10% per week for 3 weeks, plateau of 4 values over 3 weeks, any detectable level at 2 weeks, or increase of less than 10% in 1 week. Come on, all rest of you also answer.
I don't know why only 17 are answering. There's some problem with the login, maybe. They have logged out or what?
Correct answer is option number B, that is plateau of 4 values over 3 weeks. So this is persistent.
This is not their favorite subject, Archana.
Yeah.
Let's discuss.
So still we have the scoreboard with Pooja on the top, with Srishti and Devesh closely following. Let's Go is also closely following them. Let's see the final answer result. Which of the following is an absolute indication for chemotherapy following molar pregnancy? Persistent theca lutein cyst, beta HCG level of 15,000 international unit on day 7, post-evacuation and histopathological diagnosis of choriocarcinoma, or delay in beta HCG normalization beyond 10 weeks. Again, I suppose this to be an easier one. Come on, I want everyone to answer. Yes, most of you have got it correct. If you have a histopathological diagnosis of choriocarcinoma, definitely you have to go for chemotherapy. So the scoreboard more or less remains the same, ma'am. Next. In high-risk GTN with FIGO score more than 7, the preferred first-line chemotherapy regimen is methotrexate with folinic acid, actinomycin D, imaco, or MAC. We already had a discussion in the previous lectures. If you have attended it carefully, you'll are able to answer. Yes, the answer is imaco. So 9 of you got it correct. We had only 13 people.
Must have listened to the discussion.
Pooja is the leader of the scoreboard, followed by Srishti and Devesh. So next, according to RCOG and FIGO guidelines, pregnancy is advised to be delayed until 3 months after evacuation, 6 months after normalization of beta HCG, 1 year after initial diagnosis, or 6 months after chemotherapy starts. Till when you have to delay pregnancy?
This was also discussed.
So the correct answer is B, 6 months after normalization of beta HCG, but I can find that most of you have answered it C, 1 year after initial diagnosis. That is not correct. After normalization, you have to wait till 6 months. So still Pooja is taking lead with Srishti and Devesh in second and third position, ma'am. Next, which of the following factors is most predictive of poor prognosis in choriocarcinoma? Pre-treatment of beta-hCG Monwoodland 1 lakh international unit per liter, lung metastasis, history of term pregnancy or age more than 35 years, which is indicative of poor prognosis. Time is up. And the answer is option number C, that is history of term pregnancy. This carries a poor prognosis if a choriocarcinoma follows term pregnancy. So here I switch over to Archana ma'am for conducting the further quiz. Ma'am, please.
So at the end of first 10 questions, the scoreboard is led by Srishti, followed by Pooja Yadav and Devesh. Let's see what happens in the next 10. That is supposed to be the second round. So question 11, following ICOG chemotherapy for high-risk GTN, when is surveillance of beta-hCG stopped? Once beta-hCG normalizes, 3 months after last chemotherapy dose, 6 months after last chemotherapy dose, or 1 year after the diagnosis. So the correct answer is 6 months after the last chemotherapy dose, and most of you got it right. So let's see the scoreboard. Srishti leading. Next question. Which histological feature most accurately differentiate placental site trophoblastic tumor from choriocarcinoma? So you can read the answers on your own and answer. Most of you got it right. Monomorphic intermediate trophoblast with low beta-hCG secretion was the correct answer. So let's have to look at the scoreboard, remaining almost same. Next question. Patient with post-term pregnancy followed by persistently elevated beta-hCG in hemoptysis. The next best investigation is, again, an easy one. Chest X-ray, TBS, MRI, brain, CT, chest and abdomen. Oh my God, the correct answer was CT, chest and abdomen. I'm sorry, most of you got it wrong. Only 3 got it correct. The scoreboard, same again. Question number 14. Which immunohistochemical marker is the most useful for confirming a diagnosis of PSTT? Beta-hCG, Ki67, P63, HPL.
This they should answer.
Yeah, this is easy. Yes, of course.
Well done.
Shown by the result, it is HPL. The scoreboard, Srishti again leading, followed by Pooja and Devesh. Next question, in the FIGO 2000 scoring system for GTN, what is the score assigned for liver metastasis? 2, 3, 4, 5. The correct answer is 4, and I'm sorry, most of you got it 5, but it is 4. So let's see the scoreboard. Srishti again leading, followed by Pooja and Devesh. It is almost remaining same now. Question number 16. Women with history of molar pregnancy has a plateau beta-hCG over 4 values in 3 weeks. No metastasis seen. So the diagnosis is complete evacuation, persistent trophoblastic disease, invasive mole, gestational trophoblastic neoplasia. Again, a simple one. The correct answer is GTN. And only 6 of you got it right. I don't know why. But Srishti again leading the top, at the top. Next question, which of the following features excludes the diagnosis of choriocarcinoma? Rapid progression, high vascularity, elevated beta HCG, presence of chorionic villi. The correct answer is presence of chorionic villi. It will exclude choriocarcinoma, then the diagnosis would be molar pregnancy. And I think each of you got it right. Let's see the scoreboard. Pooja Yadav is now at the top. Next question. Which of the following GTD type is most likely to produce low or absent beta HCG? Complete mole, invasive mole, choriocarcinoma, epithelioid trophoblastic tumor. The correct answer is epithelioid trophoblastic tumor, and most of you got it right. The scoreboard, again, Pooja is leading at the top, followed by Srishti. Next question. Women diagnosed with ETT, which immunohistochemical profile best support the diagnosis? Positive for beta HCG, HPL and Ki67 more than 80%. Negative for beta HCG. Positive for P63. Melcam, positive for HPL, beta HCG, negative for P63 and low Ki6. Positive for cytokeratin, HPL, inhibin alpha and P63. So the correct answer is positive for HPL, beta HCG, negative for P63 and low Ki6. That was a pretty tough question. So I think only 2 of you got it right. So let's see the scoreboard. Srishti at the top again, followed by Pooja Yadav. Patient with high-risk GTN, that is FIGO score of 10, fails first-line chemotherapy. The next most appropriate step would be switch to single-agent actinomycin D, administer EMA-EP regimen, surgical excision of pulmonary nodule, add bevacizumab to Imaco. So the correct answer is administer EMA-EP regimen, and 4 of you got it right. Let's see the scoreboard. Pooja again at the top. So I think from this question, Bhavna, can you take?
Which molecular genetic feature is associated with a complete H mole? Triploidy with 2 paternal and 1 maternal set, diploidy with biparental origin, diploidy with androgenetic origin, or monosomy X with partial maternal genome retention? Which is it? With complete H mole. The correct answer is diploidy with androgenetic origin, and only 4 of you got it correct. This you must be reading the textbooks. So
yeah, this is actually an undergraduate level thing.
Yes, they should know, ma'am. No.
Yeah,
the scoreboard is being led by Pooja, closely followed by Shrishti and Devesh. But few of the answers are quite easy, and to my surprise, they're not answering. In most post-molar surveillance, which beta HCG pattern most definitively indicates recurrence after prior normalization? A single isolated beta HCG elevation of more than 20 international units per liter, 3 consecutive rise in beta HCG values above normal, beta HCG plateau at a low level for 4 weeks, or persistent low positive beta HCG over 6 months. Which is mostly associated with recurrence? How will you diagnose recurrence? So correct answer is 3 consecutive rising beta HCG values above normal. If it keeps on rising, it is more suggestive of recurrence than a plateau level. So scoreboard more or less remains the same, ma'am.
Yeah.
Let's move. Next, a patient with PSTT pregnancy presents with pulmonary metastasis. So what is the best management strategy? You will go for Imaco with lung radiation, high-dose methotrexate with leucovorin rescue, TAH with metastatectomy and chemotherapy, or surveillance beta HCG and repeat imaging. what will be your modality of treatment? The correct answer is you go for hysterectomy with excision of the metastasis and then chemotherapy. So 6 of you got it correct, not bad. Scoreboard is still led by Pooja, followed by closely by Srishti. Let's see. Which chromosomal abnormality is never associated with partial H mole? Never associated. 69 XXX, 69 XXY, 69 XYY, or 46 XX. So the correct answer is 46XX. Only 5 of you got it correct. So Pooja and Srishti taking the lead again. Let's move. Next, what is the pathophysiological explanation for early onset preeclampsia and molar pregnancy? What is the pathophysiology behind it? Elevated maternal estrogen, placental ischemia due to invasion of the trophoblast, beta HCG mediated endothelial dysfunction, or excessive trophoblastic angiogenesis via VEGF. What is the pathophysiology behind the early onset preeclampsia in molar pregnancies? The correct answer, only 2 of you got it correct. It's beta HCG mediated endothelial dysfunction, which causes this preeclampsia to set in. So Pooja and Srishti very close to each other. Let's see who will the topper. A 25-year woman with metastatic GTN, beta HCG level of around 3 lakhs, score 12. Which metastatic site will contribute least to the FIGO scoring? Lungs, brain, liver, or kidney? Which site of metastasis will contribute least to the scoring? So the correct answer is lungs, and 7 of you got it correct.
This was an easy one.
Easy again now. So we have still Pooja followed by Srishti, top 2 scorers. Which chemotherapeutic agent used in GTN is mostly associated with risk of secondary leukemia in long-term survivors? Secondary leukemia. Is it methotrexate, actinomycin D, etoposide, or cisplatin? Which is associated with secondary leukemia? So the correct answer is etoposide. It is associated with secondary leukemia, and 3 of you got it correct. Again, the scoreboard remains the same. Pooja, Shrishti, and Devesh, top 3 scorers. In a twin pregnancy with viable fetus and complete mole, which maternal complication best predicts termination? Beta HCG of more than 500,000 national per liter, onset of preeclampsia before viability, bilateral theca lutein cyst, or uterine size more than 30 weeks. When will you suggest termination? Time up, and onset of preeclampsia before viability will be an indication for termination of the pregnancy, and 4 of you got it correct. We still have 2 questions left. Scoreboard same, Pooja followed by Srishti. Let's move to the 29th question. Which molecular feature best explains the androgenetic origin of a complete mole? Loss of maternal mitochondrial DNA, biparental disomy of chromosome 7, genomic imprinting favoring paternal gene expression, and failure of meiosis II in maternal oocyte. What is it? What is happening at the molecular level? The correct answer, most of you got it correct. Genomic imprinting favoring paternal gene expression. So with this, we come to the scoreboard we can see, and then quickly switch over to the last question. Pooja has taken the lead. Which is most accurate regarding fertility after successful treatment of low-risk GTN with methotrexate? Ovarian reserve is permanently reduced, time to conception is significantly delayed, fertility outcomes are comparable to general population, or contraception must be continued for at least 2 years. So what do you think? What is true about fertility? The correct answer is the outcome of fertility remains comparable to the general population if you are treating it GTN in time. So only 4 of you got it correct. Contraception is not advised for 2 years. We had so many lectures and discussion about so many factors related to GTN. You could have answered few more questions if you would have listened properly.
Yeah, so that brings us to the end of the quiz. We'll be seeing the scoreboard. But I don't know why at the end, towards the end, the number of participants answering the questions became less and less and less. Started with 40, then 25, 20, and lastly, I think only 10 or 12 people were answering. As I said, this topic may not be interesting for them. But there was a good discussion
Very
going on.
frequently
So
asked questions in postgraduates, ma'am.
yeah, this
is an
is
important topic.
for them. Yeah, for theory as well as Viva. So let's see the scoreboard. Let's see the podium. Divesh is at third.
Divesh
Sisti
actually
at the
presented
second
the quiz.
position. And Pooja Yadav is at the top. So congratulations, all the participants.
Congratulations, the winners and all the participants also. I think Divesh was there in the case presentation.
Yeah.
But, Archana, there must be some other event
Acha, he
going
was
on in the
there.
city. And another reason may be that they have joined late, only during the time of the quiz. They haven't heard the case presentation.
Yeah, they might have joined only during quiz. So I will stop sharing.
Yeah.
Uh,
Stop sharing, and it's time to say goodbye to all of you and thank you so much for an excellent quiz program led by Archana and Bhavna and all the participants, all the faculty members. I extend my cordial thanks from the depth of my heart. You have made this. We have tried our best to make this program a successful one, and somehow this topic was not very close to their heart, I believe. That is why the students was not participating in large numbers. But anyhow,
Bhavna, we need to actually increase the sharing of the link and promoting the quiz.
Maybe that is also a reason. Connectivity also may be an issue, maybe.
That may be an issue also.
Yeah. Let's see, we'll improve next time. And till then, goodbye to all of you. Thank you so much for being a part of
Thank you, sir. Thank you so much.
Thank you, sir.
Thank you, sir. Thank you, ma'am.
Thank you for the opportunity.
Yeah.
Thank you.
It was my pleasure. Thank you so much.
Thank you, ma'am.
Thank you, sir. Bye, everyone. Nice to see Bindya, Mukta, and Santi. Bye.
Thank you, ma'am. Bye.
Bye.
Thank you so much, everyone. So from here, I'm ending this meeting. Thank you.